Test 1, 2, 3.
Recording in progress.
Well, good morning. I'm going to go ahead and call this meeting back into session. And with that, Sean, I'll let you finish eating, but would you lead us in the Pledge of Allegiance?
Pledge of allegiance to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice for all.
Thank you very much. And now, Lynn, if you'll take us through the procedure for teleconference.
Sure. Thank you, Chair Harris. This meeting is being conducted as a virtual and in-person meeting. So I will do a roll call of the trustees to confirm attendance. Mr. Raza?
Present.
Ms. Langton? Here. Ms. Fessler? Here. Mr. Kehoe? Mr. Moore?
Here.
Mr. Rue? Mr. Pantoja? Mr. Robbins? Mr. Harris?
Here.
Mr. Green? Ms. Ginsburg? Ms. Proft? Okay, trustee DeRosa will be participating under teleconference policy SB 707. Ms. DeRosa is taking care of her mother. Ms. DeRosa, can you please confirm if there are any individuals 18 years or older present at your location?
No one is present at the moment.
Okay, thank you.
Thank you very much. Public comment, have we received any public comment? I don't see anyone waving their hands in the back of the room, so thank you very much. That brings us to welcoming remarks.
Good morning. Thank you, Chair Harris. Good morning, trustees. Good morning, staff. Again, welcome to day 2 of the 2026 Board of Retirement Offsite. Appreciate the engagement yesterday, the energy yesterday with 9 sessions. I know that was quite a bit, but look forward. We trimmed it down a little bit for today. We have 6 sessions today on the docket. But again, appreciate the trustees' engagement throughout each session. So we're going to continue with the legal office, and we're going to have Jean Kim, Senior Staff Counsel, as well as Ching Fong, Senior Quality Auditor with the Quality Assurance Division, and give an overview on pensionability determination process. So with that, please join me in welcoming both Jean and Ching.
Thanks, Louis. Good morning, Chairman. Good morning, trustees and staff. My name is Jean Kim, and I'm Senior Benefits Counsel. I'm back again today for day 2, and joining me today is Ching Fong.
Good morning, ladies and gentlemen of the board. My name is Ching Fong, and I'm a Senior Quality Auditor in the Quality Assurance Division. I've been with LACERA for over 20 years, but I took over the pay codes processing QA about 4 years ago after my predecessor left.
So in this presentation, we will be going over LACERA's pensionability determination process. This will include an overview of the collaboration that occurs between LACERA and the county CEO's office, as well as the Superior Court. Ching will talk about the role that quality assurance plays in this process. I'll go over the legal analysis, and then we'll end by talking about some of the improvements that we've already implemented into the process, as well as some that are in the works. So the pensionability determination process is about determining which items of pay meet the legal standard to qualify as pensionable earnings, and therefore be included in a member's final compensation. This is a key aspect of calculating a member's ultimate retirement benefit, and so it's a very consequential determination. This process is also a core function of LACERA, but it's also a process that requires close collaboration between LACERA and the county CEO's office, as well as the Superior Court. So I'll pass it to Ching to talk more about that collaboration, as well as the role of quality assurance.
The pensionability determination process is a collaborative effort involving several stakeholders. This slide shows the different stakeholders that the process flows through before pensionability determinations are finalized. The process is initiated by the LA County Chief Executive Office or the Superior Court. The Quality Assurance Division is a point of contact between LACERA and our external stakeholders. The process travels down the pipeline to our legal division over benefits, and then to our executive team for final review. Finally, the process concludes with the Board of Retirement. This slide summarizes the responsibilities of each stakeholder during the pensionability determination process. The process begins with a request sent to LACERA by the county's CEO office or the Superior Court. The CEO or court provide LACERA with the information needed to analyze the pay item. The Quality Assurance Division reviews the materials and drafts an analysis on the pay item. QA analyzes the pay item under the definitions of compensation earnable in SERL, Section 31461, and pensionable compensation in PEPRA, Section 7522.34. In our analysis, we cite the reasons why a pay item might be pensionable or non-pensionable under SERL and PEPRA. We then submit our analysis to legal. Legal reviews QA's analysis and prepares a memo to the Board of Retirement with its recommendation on pensionability. LACERA's executive team reviews legal's recommendation before it is presented to the board. After the board reviews and approves legal's recommendation, QA notifies the county or Superior Court of the board's pensionability determination for the pay item requested. In this slide, I will elaborate on QA's part of the process. The documents we get from the county or court are typically MOUs, terms of successor MOUs, side letter agreements, Board of Supervisors memos, or other county department correspondence. QA reviews these documents to learn as much as we can about the new pay item to perform our analysis. It is not uncommon for these documents to contain sparse information or vague language on the pay item. So in addition to the documents received, QA normally corresponds back and forth with the county or court to get our specific questions answered. This back and forth can last several weeks. This slide shows the main information we need to perform the analysis, the 4 W's and the how. Who is eligible for the payment? We need to know the eligible job classification. If only a smaller group within the classification is eligible, such as a group that works at a specific location, we need to know that. Is the pay item actually paid to all employees in that group or classification? Or is the pay item simply eligible to all employees if they meet certain criteria? An example of a pay item that is actually paid to all in a group or class is a bonus for possessing a license that is required for the job title. In contrast, a pay item that is simply eligible to all will be a bonus for a certification that's optional for their job title. What is the purpose of the payment? What is the pay rate? We need a detailed description of the pay item, especially since it's being introduced for the first time. When is the payment made to employees? We are looking for start dates, end dates, and the frequency that payments are made. Why and how do employees qualify for the payment? Are there requirements an employee has to meet before becoming eligible for the payment? Or is it automatically paid because a specific event occurred, such as the MOU signing bonus that is paid to all bargaining unit members after their MOU has been ratified? How is a payment made? Is it a percentage increase to the monthly base salary rate? Is it a flat dollar bonus that's not part of the base salary rate? Is it a one-time payment or an ad hoc payment? After QA gathers all the information we need, we compare the characteristics of the pay item to the definition of compensation earnable in SERL and pensionable compensation in PEPRA. We draft our analysis with our proposed recommendation and forward it to the legal office.
The benefits legal review for pensionability is a 3-step analysis. First, we determine whether the pay item qualifies as compensation under SERL. If it does, then we analyze whether the pay item meets both the legal standard for compensation earnable for our legacy members, as well as the standard for pensionable compensation for our PEPRA members. Finally, we evaluate whether the pay item falls within any of the statutory exclusions from compensation earnable or pensionable compensation. The first step in determining pensionability is evaluating whether the pay item meets the basic definition for compensation under SERL. SERL defines compensation as remuneration paid in cash out of the county or district funds or payment for services performed by a member. It's actually pretty rare for a pay item to not meet this very basic and broad definition, which is why we thought it'd be interesting to share an example of a pay item that does not meet this standard. This is a pay item that we recently reviewed. It's a living allowance stipend that would be paid to Justice Corps volunteers who are assigned to the Superior Court. The pay item was created to only ever be paid to this group of volunteers. The volunteers are not court employees, but rather volunteers for Justice Corps. And therefore, this pay item did not meet this basic definition of compensation. Once we've determined that a pay item is compensation, we then analyze both whether it meets the standard for compensation earnable for our legacy members and whether it meets the standard for pensionable compensation for our PEPRA members. The court in the Alameda County Deputy Sheriff's Association versus Alameda County case famously characterized the definition of compensation earnable as both very general and somewhat inscrutable. The court ultimately interpreted it to mean the average pay of the retiree member that is computed on the basis of the number of hours worked by other employees in the same class and pay rate. So pretty broad. In comparing these two legal definitions, you'll note that the definition for compensation earnable is much broader than the definition of pensionable compensation. And that's really due to the fact that the definition for pensionable compensation requires that the compensation be actually paid to all similarly situated members of the same group or class. This is not the case for compensation earnable, where based on the definition, even if an item of pay is not paid to everyone, but everyone's eligible to receive it, it could still be pensionable. So that's a key difference. Finally, if we determine that a pay item does meet the definition of compensation earnable or the definition of pensionable compensation, then we still need to determine if it falls within any of the statutory exclusions. And the exclusions are really where the action is. Because the definition of compensation earnable is so broad, if an item doesn't fall into one of the 4 statutory exclusions, then it likely is pensionable. Similarly, for pensionable compensation, since there are 12 categories of exclusion, we will generally look to see whether an item falls within one of these exclusions first. Here you'll notice again that because there are far fewer exclusions from compensation earnable, the result is that the standard for pensionability for our legacy members is much broader or easier to meet. Conversely, it is a much stricter standard for what qualifies as pensionable for our PEPR members. There are generally 4 categories of excluded items from compensation earnable, 1 broad catch-all category with a couple examples, and then 3 specific call-outs. In contrast, there are 12 statutory exclusions from pensionable compensation. Generally, all the exclusions that apply to compensation earnable apply to pensionable compensation as well. And then there are 8 additional exclusions, and we've highlighted some of those key exclusions here. Also note that for a couple of the exclusions, while they may look the same on both sides, that exclusion is much broader on the PEPR side. So for example, the one-time or ad hoc payment exclusion on the legacy side is only excludable if it's not paid to everyone in the same grade or class, but there's no such limitation when it applies to PEPR members. It's just any one-time or ad hoc payment. Same thing with cash outs for vacation or leave. If the exclusion is much broader for PEPR members because there's no limitation. It's not limited to the excess of the annual maximum amount as it is for legacy members. Here we've provided some examples of pay items and their pensionability determination for legacy members and PEPR members. Starting out with the most straightforward example, overtime is a statutory exclusion for both legacy members and PEPR members. MOU lump sum bonuses are a one-time bonus that's paid to the entire bargaining unit upon the ratification of the MOU. For legacy members, it is pensionable because while it is a one-time payment, it's paid to everyone in the same classification, and so that saves it from being excluded. It's not pensionable for PEPR members because it is a one-time payment.
What's the difference? It's a one-time payment, everybody in the bargaining unit gets it, but not the people in the bargaining unit that are PEPR members. Is that what you're saying?
No, I'm saying that it's a bonus that will be paid to everyone in the bargaining agreement in accordance with the MOU. However, it's a one-time payment, and one-time payments are just excluded for PEPR members.
What kind of a bonus?
An MOU.
Something that they negotiate at the bargaining table,
Yeah,
cash in lieu of base rate salary increase. Is that what we're talking about?
a one-time payment, however it's structured, upon the signing of the MOU.
Can I follow up on that?
Yeah.
So for example, County Counsel's office received $5,000 last year in lieu of a percentage increase as part of their raises. Does that mean that legacy members would have that pensionable, but PEPRA members would not?
It sounds like it's an increase that is an ongoing increase and
was
not
just
a
once.
one-time
It was
payment.
once.
Oh, it was just a one-time
Yeah.
payment. If it was strictly a one-time payment without having more detail on
Yeah,
the
fair.
description of the pay item, I would say that that exclusion would apply for PEPRA members.
Yeah, so that's kind of a problem, but I guess we'll deal with it the first time it comes up by a PEPRA member.
May I follow up on that question? This pensionability is only, let me back up. Am I right that if, for example, Aline is a legacy member in county council and I'm a PEPRA member on the situation she just described, but neither of us is retiring for 10 years. And by the time we retire, our salary is going to be, our final compensation is going to be a lot higher than it is right now. Does that mean that this $5,000 payment in regards to the two of us is really irrelevant to what we get as our retirement benefit?
Well, presumably you would still be receiving, or no, it's just
No,
a
it's just
one-time
a
payment.
one-time.
Right,
yeah.
so it wouldn't be included in your final average
Okay.
compensation.
So a lot of what we're talking about here, especially with these one-time things, might only be relevant with regard to people that are retiring for when that one-time payment was included in their highest compensation. Is that right?
That's correct.
Okay.
It's going to be an issue once the PEPRA members are retirement age and starting to retire. That's going to directly impact them. So definitely right now it's not going to impact them, but it's a problem that's definitely coming down in the future.
Well, but if it's a one-time payment, and they get it in 2026 and they retire in 2032, and in the meantime, they've gotten salary increases either because they've been promoted or because they've gotten raises or whatever, the $5,000 that they got in 2026 won't have any effect on what their ultimate retirement is because it'll be based on the compensation they earned in 2032, right?
The final average compensation
whatever
period
that-
that they choose.
Exactly.
Right,
Yeah.
right.
Okay.
That's correct.
Thank you.
Correct. And in 2043, though, if they're retiring in 30 years from now after the 2013 law change, then that group receiving a final payout or getting a payout in a negotiated contract, they would not have that pensionable, whereas legacy members do have a pensionable at this point. So it's definitely on the radar for PEPRA members, and it's concerns that have been brought up to me directly from PEPRA members. So they're paying attention to. I mean, it's plan design, so it's not under the purview of us and our board, but we definitely have to be aware of that kind of two-class system that's going on right now and the concerns from the individuals that are under PEPRA.
Yeah, that's correct. So moving on to the last example, this is a bonus that is paid. So this is an actual pay item that we made a determination on, and it's a bonus that's called the Catalina Island Living Bonus. It's paid to firefighters who are assigned to Catalina and are required to reside there. They're assigned to the beach and boat rescue operations. It's also a pay that involves a percentage boost to their base salary. It's embedded in their base salary. And so for legacy members, this is a pensionable pay item because it's embedded in their base salary rate. It meets the definition of compensation earnable. It's basically a part of their average pay, and it doesn't fall within any of the 4 statutory exclusions. Similarly, for PEPRA members, we also determined that it was pensionable. That's because it meets the definition of pensionable compensation because it's compensation that's paid to everyone in the same group. all firefighters who are assigned to Catalina. And also, it doesn't fall within any of the 12 statutory exclusions. You'll recall that one of the exclusions is an exclusion for bonuses. So this is a good example of how our analysis really needs to go beyond how a particular pay item may be labeled. So while it's called a bonus, we analyzed it to be more like the normal monthly rate of pay because it's embedded into their base pay. It's ongoing. It's paid to everyone in the same group, the firefighters who are placed in the same assignment, and it's not tied to any other metrics such as performance. And so that was why we determined it to be pensionable.
Can I ask if there is a separation based upon a rank structure, does that then make it so that it no longer applies? So if, say, the firefighters received it, but the fire captain was excluded, are we looking at firefighters as a group and all firefighters on the island? So that would be included, or does the rank have a complicate things?
Yeah, I think that you're going to how do we define group? And I think that in this case, we define the group as everyone who was assigned to Catalina. And if the question is whether we could make carve-outs from that group and have it still be qualified as a group, I feel like that's a harder argument to make.
Oh, I'm not making the carve out. Who carved out the agency is, right? So they're saying this is a manager or supervisor at a different rank and has different job specifications. And this is a firefighter, which is a different rank, which has different specifications. So all firefighters on the island this is a real example with deputies. So the deputies on the island receive a bonus, but the manager, the captain, does not receive that bonus. Does that then make it so that the entire bonus for all deputies on the island is excluded or not?
Yeah, how would you think about that, Gene?
You don't have to answer that specific example, but I'm just curious how granular we go and how the law defines that. Because ranks complicate things sometimes within the same group of individuals.
Is rank the same classification though, or are you talking about a higher rank with a different classification, and then you have the deputies item number 2708 under that, like 2717, and then there's a 2708?
Yeah, they would be a different item, like a firefighter and a captain would be a different.
Okay, different classifications
would be different.
So we want to look at the classification first. So if I guess you have several of the higher ranking ones, right? So several of I'm just going to use the item number 2717. They all have to be paid it in order for it to be PEPRA pensionable. But as for Catalina, because when we look at the classification of the firefighters, not all firefighters work in Catalina. So that group, that's sort of carved out into a group because they all receive it in Catalina. That's why it's pensionable, even though the entire classification of firefighters do not get that bonus. So as far as rank, we want to look at everyone in that rank. Do they get it? But if not, is it because this rank works in Catalina? Then they would get it because then we would carve it out to the group. Does that make sense?
It's a very fact-specific analysis, and group is not defined in Searle.
Okay, yeah. It's good enough for me now.
Okay, because the pensionability determination process is such a critical function of LACERA, QA and Benefits Legal have been working together to make sure that the process continues to be sound. One change that we implemented 2 years ago is creating this pensionability calendar. We started with all the scheduled BOR meeting dates for the upcoming calendar year, and we worked backwards and assigned deadlines to all the different stakeholders in the process. The date in the first column, the leftmost column, is the deadline for our external partners, the county CEO's office and the court. And it gives them the assurance that if they provide QA with their request, as well as all the necessary information, then they have the assurance that that pay item will go before the board on the corresponding meeting date. We prepare this at the end of every calendar year for the upcoming year and share it with our partners. And we think that it provides good transparency into the overall process, as well as a nice predictability. Also, other improvements that are in the works are QA is working on formalizing and documenting their review process. Ching has worked hard to create a checklist for both the county CEO's office and the Superior Court in an effort to streamline the fact-finding process. And then for Benefits Legal, we're in the process of creating a library of all past legal pensionability determinations. And that concludes our presentation. Any questions? Yes?
Can we go back a few slides to the, well, let's go back a few slides and I'll tell you when. Yeah. Was this the one that explains?
Exclusions?
Yeah. Maybe it's the one before. Could we go back one more? Sorry, I forgot my iPad upstairs.
This is the definitions.
Well, I'll just ask my question and then see where the slide lands. Comparing legacy to PEPRA again, using your additional, I guess, time to pension spike. Can we talk about is that considered pension spiking? Oh, let me rephrase. What's considered what's pension spiking, and is it legal? It's not legal. Okay. Okay. So, but I hear people do it. So, what is that?
Yeah, that was one of the motivating concerns behind PEPRA. And it's this idea that members will artificially inflate their final average compensation so that they can have a higher ultimate retirement benefit. So a classic example would be somebody who saves up a lot of vacation, excess vacation, and then cashes it all out in their final average compensation period, which is why one of the exclusions under PEPRA is that you're not allowed to include vacation cash outs, because that's an item of pay that was easy to manipulate.
Okay, but people do that in legacy.
Even for legacy members, PEPRA included an amendment to compensation earnable, and they included that vacation cash outs are excludable to the extent you're only limited to your annual maximum amount, what you can earn and be paid out in a year. And so anything beyond that amount would not be includable.
Okay, and we don't have sick time, but we have non-elective leave. I don't know if you guys have the
Leave
same
cash
thing.
outs are in the same category.
So, oh yeah, go ahead.
I just wanted to add something to that, because even before the additional language was added to SERL, where it was limited to what you could earn and be paid within a year, we have never ever allowed more than 1 year anyway. So members were never allowed to spike beyond what was earned and payable within a year for a sick buyback, vacation buyback, holiday buyback, non-elective, all those buybacks. So it's been the same pre-PEPRA and post-PEPRA for legacy plans.
So basically
That's
you
the
can,
Ventura decision, though.
The
right?
Ventura decision,
That
yeah.
was
Well,
defined in the Ventura decision.
with Ventura, they added a lot more pay items that could be pensionable, and these were more of the non-base pay type of items. So like the buybacks, because a long time ago, buybacks were not pensionable, period. But after the Ventura decision, buybacks became pensionable, but it was limited to what you could earn and be paid within a year.
so spiking is legal within a year.
It's not considered spiking. It's I guess with the Ventura decision, it was allowed and it was limited, but I wouldn't consider that spiking.
Yeah, if I may,
Yeah.
it's not really spiking. Spiking, let's say in your last year, you were suddenly given a bonus for doing something you're not doing. That would be more spiking. And that's actually, I think, what happened in Bell, if I remember correctly, is the gentleman either was doing multiple jobs at one time in Bell is what really led to Pepper. That was like the last straw that broke the back of the camel. But that would be something like that, something that you got specifically just you know, some different pay code that normally wasn't part of your job. That's typically what they consider spiking.
But, okay, so what I'm hearing is you can't gather up your vacation and overtime and non-elective leave for 3 years and then cash it out and use that as your last year final income for legacy. But you can do that for a 1 year period.
For that
last-
to answer the
For the 1 year.
For the 1 year, because we have had cases where members are about to retire and they will cash out 300 or 400 hours, but we will limit it to what you are able to earn and pay, or what's earnable and payable within 1 year.
Okay, but
so
then
they can
that's,
cash it out. It's just that we wouldn't include the full amount in calculating the retirement benefit.
okay, so but it's like, I feel like it's a matter of semantics. It's, if one is spiking, if you're doing it for 3 years, why wouldn't one be spiking if you're doing it within the year that you're allowed? I mean, only because it's allowed? Is that why it's not spiking? Spiking isn't a
Can I
bad word.
give a comment? 'Cause
Yeah,
what it is within your 1 year period, they're looking at your salary that you earn within a 1 year period. During that 1 year, people typically will cash out their sick time. And that's something that you live on. So you're used to it, you're living on it throughout your career. In your final year, that shouldn't be then excluded and then negatively impact the member. So that's ultimately my guess on why the Ventura decision allowed that 1 year, whatever you earned within that 1 year. So the vacation cash out, the sick cash out, any of the things, F time for some departments allow F time cash out, the non-elective leave for exempt members. So those kind of things that you would typically get within that 1 year that you would typically survive on, or that'd be part of your salary. But what they don't want you to do is they don't want you to build up, 5 years, 3 years, 10 years, cash it out and then have a massive pension that's not real. So it was what was determined to not be, that's the breaks of the spiking, so that what you get into that 1 year is reasonable. Anything beyond that is not reasonable. So it's actually to rein in spiking back then in Ventura, and it got codified and very granular in PEPRA to the point where it's exceptionally granular and there's real members being impacted negatively. For example, sworn members do not get their intermediate or advanced post as pensionable because it's not offered to everybody in the same class. They have to do a few extra college classes to get that. So they got a little extreme on one end, but that's the whole purpose kind of where PEPRA came in. That 1 year is definitely not spiking. It's what you would earn typically within that year.
got it.
And
Thank you.
just follow up on what JJ had said earlier. The city manager of Bell hosed the entire operation. And what he did wound up, among other things, leading to him going to prison. So a lot of his very specific efforts to jerk around the system were ultimately found to be illegal. And he was doing it specifically to jack up his pension base, not as Sean was describing, as something that was a routine part of his ongoing salary and benefits. And as is often the case, the legislature threw the baby out with the bathwater. And in an effort to fix a standalone horrid issue, they went way overboard, and it's now negatively impacting honorable people who aren't in any position to have that authority to play games with their pension, and creating long-term impacts on what they're able to earn as their retirement benefit, because it was an overreaction. But I think the real distinction is the difference between something that is part and parcel of what you would have available to you as an employee, a routine part of your salary, and something that you've manipulated to unduly influence what your retirement is going to be based on.
Okay, thank you. That was very helpful.
Can I just ask one question? Oh, I'm sorry, go ahead. And I have a question separate to this.
It's just a clarification. Non-elective leave is never pensionable. So that's the time that you actually purchase. For those that can do that, you can buy up to 20 hours, I think.
I think that's elective. Non-elective, we get it.
Oh,
in
yeah,
lieu
you're
of
right.
sick
I
pay.
apologize.
Yeah.
I apologize. You're right. Thank you, Sean. I appreciate it.
So vacation, well, we don't get vacation, but we get non-elective and we get, I think that's all we get. We just get non-elective. So that's all you could sort of gather up for your year.
You can purchase elective, which has no pensionable value to it.
Right.
You earn non-elective leave. If you end up not using it and you go into excess and it's cashed out, that's a lot of check off boxes that happen. But if it all happens, then that time is pensionable up to 80 hours.
For 1 year, for the 1 year,
The 80 hours.
80 hours.
You'll
Okay,
you'll get the remaining balance cashed out on behalf of the department, but
Not
that
pensionable.
will not be pensionable.
okay. Thank you.
May I ask, are you finished?
Yeah, I just wanted to add that those limits for the non-elective leave, they're actually referenced in the county code. So it tells you that it's 80 hours that you could cash out in a year. Also, for the represented employees, a vacation, that is referenced in the fringe benefits MOU. So those numbers are there, and those are the numbers that we follow.
I had a separate question. And I'm not sure if you guys are the right ones to answer this. With respect to some kind of raise or bonus or whatever that isn't pensionable, but is of an ongoing basis. So not everybody got it, but I keep getting it for many, many years. There is such a circumstance, correct? And then that $50 a month or whatever it would be isn't pensionable. Is that amount included in the calculation on how much I have to contribute to LACERA every month? I mean, I've got a certain percentage that I contribute to LACERA. It's a percentage of my salary, right? So I don't know what the numbers are, but say it's 10% or 8%. Would that $50, would I be paying 8% on that $50? Okay, so that decision is made early enough on that, and then somebody goes into the system, and I guess would be the county auditor controller or somebody who goes in and adjusts so that my 8% is paid on $1,000 minus 50, $950 instead of 1,000.
The auditor controller, so after the pensionability determinations are provided by the board, we notify the auditor controller, and they program EHR, the payroll system, so that if it's a non-pensionable pay item for PEPRA, it'll be labeled as non-pensionable, so they will not collect contributions on that pay item, and they have specific pay codes for each pay item. But for legacy, if the same pay item is pensionable, then they will label it as yes, pensionable. They'll collect contributions on
What a
that.
nightmare. Okay, that while you were talking, that was in my mind, and I'm thinking, my God, it's like a pot of spaghetti, right? And you pull out one piece and it's tied to 17 other ones. Yeah. Okay.
It's been getting harder for them.
I'm sure.
Okay, thank you. Thank you.
Good morning, everyone. Let's start our Retiree Healthcare Day off. We're going to start with our beginning, which will be the Washington Health Update provided by Amy Dunn from Siegel Consulting. Amy is the Senior Vice President and Senior Consultant in Siegel's Health Compliance Office, our practice. She has more than 20 years of compliance consulting experience, navigating federal, state, and local health and welfare laws and regulations. She earned her JD from Whittier Law School, holding a master's in health administration and a BA in organizational leadership from Chapman University. Amy?
Good morning. Can you hear me all right? Oh, I'm so thrilled to be back here again. I was just reflecting last night. This is my 4th year in doing this presentation, and I always love our discussions and our sharing of information. So I'm thrilled to be back again for a Washington Health Update. So with that, let's go ahead and get started. I'm going to give some updates on Medicare Part D and Medicare Advantage. We'll start with that. So over the last few years, we have talked about the Inflation Reduction Act. And the Inflation Reduction Act was signed into law in August of 2022. It included changes to Medicare Part D intended to control prescription drug costs, cap maximum retiree out-of-pocket costs, and simplify coverage for Medicare enrollees. And the measure was passed using a budget reconciliation process, which permits passage with just a simple majorities in Congress. And so the Part D, just to give you an update, Part D deductible for 2026 is $615, and for 2027, it's going to increase to $700, as well as the out-of-pocket maximum in 26 is $2,100. That's going to also increase to $2,400 as well. Another part of this too, and I have a little bit of breaking news for you on this subject, for Medicare prescription drug negotiations. And so under the Medicare Drug Price Negotiation Program, the Centers of Medicare and Medicaid Services, also known as CMS, directly negotiates prices of certain high expenditure single source drugs without generic or biosimilar competition. And so last year, Medicare announced and ultimately negotiated prices for certain high-cost drugs. And at that time, those drugs included, for example, Rybelsus and Wegovy. Well, this year, in January, the CMS announced that the next 15 drugs were up for negotiation based on total expenditures for drugs payable under Part B and or covered under Part D and other criteria as required by law. They included up in the list to highlight for you is Trulicity, for example, for type 2 diabetes, Biktarvy, which is for HIV-1 infection, Orencia, as well as Botox, but for chronic migraines, not for the popular reason cosmetically we might think about that. But just a little breaking news, just yesterday, the United States Supreme Court declined to hear the pharmaceutical industry challenge to plan to curb Medicare drug prices adopted under this law. They left actually decisions by the lower courts rejecting various legal claims against drug price negotiation plan, which was ultimately part originally of the Inflation Reduction Act of 2022. That just happened yesterday. So with that, I actually want to move into a whole new thing talking about, and I know later this afternoon there's going to be a whole discussion about GLP-1s and that whole panel kind of discussion, but I want to talk about two models that are coming that we're keeping an eye on, and they're known as the balance and bridge models. And so CMS previously introduced the balance model as a pathway to expand Medicare coverage for GLP-1 drugs, specifically for obesity treatment. The balance program actually stands for Better Approaches to Lifestyle and Nutrition for Comprehensive health. They had to find that E in there somewhere to make the acronym work. So as you can see, that's not a typo in health. It's just the capital E for the word balance to work. Currently, Medicare covers GLP-1 drugs for diabetes, cardiovascular disease, and severe obstructive sleep apnea. However, CMS has now announced that that model will not launch on January 1st of 2027 as originally planned. The reason for the delay is limited participation from Part D sponsors. And so if you think about it, the Balance program was really looking at those Part D sponsors, or for example, those insurer types of plans. The Bridge program, which I'm going to talk about in a second, is just involving CMS. So, CMS indicated that it's going to continue its negotiations with Part D sponsors, suggesting the model is not canceled, but it's rather postponed. So in the meantime, CMS is going to roll out this temporary solution funded by CMS, known as the Bridge program. And the Bridge program is designed to provide access to GLP-1 medication weight loss starting July 1 of 2026. Originally, the program was set to expire December of 26, so for example, just 6 months, but now will run through 2027. And again, we're getting some more information about what this Bridge program is going to look like, but it's unclear what it's going to look like after that expiration point. CMS and Part D insurers both signaled that they hope to have more utilization and savings data available from the Bridge program to allow for Part D sponsors to adequately calculate the cost risk of that program. So let's talk a little bit more about what this Bridge program, again, that CMS is leading, what that's about. Again, starting July 1st of this year, and it's lasting about 18 months through 2027. The program is designed to provide early access to GLP-1 medications such as Wegovy and Zepbound, specifically for weight loss and for long-term maintenance. But it's important to note that this coverage is limited to specific drugs selected by CMS. So not all GLP-1 medications will be included, for example, Ozempic. Eligibility is restricted to Medicare Part D enrollees who meet certain clinical criteria, such as specified BMI or a chronic condition and diagnosis. Those who qualify use a simplified payment structure at the pharmacy, a flat $50 copay with no deductible. However, these payments do not count towards the Part D out-of-pocket maximum, or that true calculation, that true out-of-pocket calculation. And this is important for any beneficiaries that are managing their total drug spend. So this is a unique feature of this program, that it operates directly between CMS and participating pharmacies, rather than running through the Part D plan. So any pharmacy not on the CMS preclusion list with CMS can participate. And CMS will release guidance to pharmacies on how to process these claims and identify whether they go to CMS or, for example, if they're going to the beneficiary's plan. For example, there might be a co-diagnosis going on there. For example, the person seeking the drug for weight loss, but perhaps they also have diabetes. And our understanding is that Humana will be the processor for these claims. So more to come definitely in this space, especially again, later in today, more of the vendors will be here as well. Again, we're learning about this program as we go forward. So let's talk a little bit about a legislative update and as a general theme in legislation that we've seen, and this was a larger space, is really looking at pharmacy benefit managers, or PBMs, and PBM legislation, including reporting and fee disclosures. So under the Consolidated Appropriations Act of 2026 that was signed into law in February of this year, and it acts full funding of 5 appropriation bills and makes significant reforms to the PBM practices. The PBM reforms affect employment-based group plans and insurers, as well as Medicare. Generally, the CAA PBM provisions are effective for beginning on or after August 3rd of 2028. So 30 months after the law's enactment date. So for calendar plan years, generally speaking, these requirements are going to be effective January 1st of 2029. So we have some time, and we're learning of the shape of these as we go. First, there's going to be mandatory PBM reporting. So PBMs would have to submit reports at least every 6 months to large plans and employers with over 100 participants. And the reports must list drug claim information and provide detailed information about compensation, gross and net drug spending, drug rebates, formulary placements, and rationale, and as well as those benefit design that encourage the use of pharmacies affiliated with PBMs. But with that also, there is mandatory plan reporting. So each plan year, group health plans need to provide written notice to each participant or beneficiary, informing them of the requirement for entities providing PBM services to submit reporting to the plan. Notices may be incorporated into plan documents or via individual's notification. Additionally, group health plans must provide different kinds of information to participants and beneficiaries upon request. For example, that summary notice document, as well as what may also turn into specific claim information on behalf of the individual, or what the difference between the compensation paid by the plan and compensation paid to the pharmacy. But into this, they talked a great deal more about Medicare Part D. And so the definition of a PBM for purposes of Medicare Part D, on the provision of this 2026, the CAA, the law defines the pharmacy benefit manager broadly to extend beyond traditional PBMs. It also includes rebate aggregators, group purchasing organizations, and utilization management entities. Talking about transparent compensation and pass-through rebates, PBMs that act on behalf of prescription drug plan sponsors may receive compensation related to Part D drug utilization only in the form of what's known as a bona fide service fee. The law prohibits PBMs from receiving other income tied to Part D drug utilization. For example, 2 additional PBM agreement requirements to evaluate PBM performance against pricing guarantees and other rebate-related cost measures. The new law requires prescription drug plan sponsors and PBM to structure their actual agreements in a certain way. For example, to define and interpret key terms in a transparent and consistent manner. For example, what is a generic drug, a brand drug, specialty drug, rebates, as well as clearly identifying any claims or price concessions that the agreements exclude from pricing guarantees and other performance guarantees. Standardized reporting requirements, this is actually going to begin in 2028, that the PBMs are going to be required to submit standardized annual reports to prescription drug plan sponsors and to the Department of Health and Human Services. These reports, again, it's going to have a lot of different data points in it, but at a high level, it will include comprehensive drug level and aggregate data, including pricing reimbursements and amounts, enrollee out-of-pocket spending, dispensing activity, formulary and benefit design information, aggregate spending metrics, as well as the PBMs are required to provide to prescription drug plan Part D sponsors in a written, with a written explanation of rebate contracts within 30 days of finalizing each contract. And then finally, audits. Prescription drug plan sponsors may audit the PBM's compliance with applicable legal requirements on an annual basis. The law requires, too, that PBMs provide all requested audit information within 6 months after the Part D sponsor initiates an audit. Now, in practice, Part D sponsors may already retain tighter audit times in their agreements that may require a faster turnaround time, but this appears to be a floor to that as well. So with that, I'm going to go through and talk about a regulatory update and things that we're hearing more in Washington. The most favored nation prescription drug policy. So back in December of 25, this administration proposed 2 Medicare pilot programs to reduce prices of both brand name drugs and drugs administered in providers' offices. Both programs would have mandatory requirements to provide rebates equal to the difference between prices in the United States and an international benchmark based on what 19 other comparable countries pay. For example, some of those countries are Australia, Canada, Denmark, and et cetera. Continuing on this subject is one of the different policies. One is called the GLOBE proposal, which is to have the most favored nation pricing applied to Part B drugs. And the second is called the GUARD proposal to apply the most favored nation pricing to Part D drugs. And again, both of these are proposals at this point. And if finalized, then the patient out-of-pocket costs in Part B and Part D would be tied to an international benchmark price. If these models, if they're going to be implemented, they're going to be implemented in randomly selected geographic areas, representing about 25% of the individuals in Part B and Part D. Both of the programs are pending final rule, which is anticipated in August of this year. With that, you may have also heard about the Great Healthcare Plan. And so this was announced in January of this year and again mentioned in the State of the Union address in February. This is, again, a big picture legislative framework that was proposed by the current administration, and it aimed at reducing healthcare costs through 4 main pillars: lowering prescription drug costs, reducing insurance premiums, increasing insurance accountability, and maximizing price transparency. And so these key components include capping drug prices based on, again, those international benchmarks, directing insurance subsidies directly to consumers instead of insurers, and expanding over-the-counter medication options and requiring providers to post prices. And so since some of the proposals included in the plan have already included proposal that the administration has already released some of these, including, again, that most favored nation pricing, proposals for Part B and Part D, and the transparency in coverage types of rules. Other proposals in the plan will require legislative action, and so including the PBM reform measures currently, again, also in Congress. So a lot more, again, of the vision of what I think what they're ultimately looking for. And so in addition to this, we're seeing in the pipeline more information coming through about regulations under the No Surprises Act. You may have seen about that, where for example, out-of-network type of spending information. Again, more regulations coming out about that. But then there was also, the final bullet here is the Trump RX program, and talking about this, and we'll talk about this a little bit, offering direct-to-consumer pricing, specifically, for example, on GLP-1 and other types of drugs. And so let's talk about this because I have a little bit of breaking news for you about this as well. So the Trump RX website, it went live in February of this year. And at the time, it was about 40 medications or so that were available through either some type of coupons or links to manufacturer direct-to-consumer pay sites, including GLP-1s and fertility medications. But more than half of those drugs at that time were old brands with generics or generic alternatives. And so at the time, we were thinking patients should really look into this site before using it, because with making sure they're doing additional research. Prices could be higher on that website than actual copays for a plan. There might be cheaper alternatives, and alternative drugs or generics may be available. Some prices might have a starter price, but then start to increase as the dose increases. The drugs that they do not pay the rebates, so price comparison to looking at the plans might be a little bit more difficult. And again, the last bullet that we have here in sharing this is that many PBMs also offer lower consumer cost, like GoodRx, to their PBMs now. And that's where the breaking news comes in. If you saw the news yesterday, that President Trump yesterday announced that his administration is adding more than 600 more generic drugs to the Trump RX website. And alongside of that was Mr. Mark Cuban. Mark Cuban, through his site Cost Plug, the drug company, sells mail order medications directly to consumers. And so discounts offered by that company will now be available on the Trump RX website, as well as GoodRx, and as well as our understanding is the Amazon.com's pharmacy division as well. So again, that just actually happened yesterday. So if you were watching the news, we noticed that there for you as well. So with that, I'm happy to take any questions, as well as our Siegel team, but I know there's a lot more conversation happening later today with drugs and specifically GLP-1s. With that, thank you all very much. Thank you. Thank you. Thank you. Appreciate that. Thank you.
You back here, a little ahead of time, so, if we do back here.
All right, we're gonna reconvene this august body and launch into healthcare landscape. So Cassandra, go ahead and take us down the road.
So our next presentation is on the medical and prescription drug plan trend highlights. This is being presented by Daljeet Joel. She's Vice President and Pharmacy Benefit Consultant out of Siegel's San Francisco office. She's a registered pharmacist and has more than 25 years' experience in the pharmacy benefits. She holds a Doctor of Pharmacy degree from the University of California, San Francisco, and a BS in biology from California State University. Along with Daljeet, we have Stephen Murphy, Senior Vice President and Benefit Consultant, and as well as Michael Zito, who's Senior Actuarial Associate. Daljeet, Steve, Michael, have it.
Good morning, everyone. Thanks for your time and the opportunity to be in front of you again this year. So as Cassandra pointed out, we're going to go over the healthcare landscape. So this will provide some context with regard to kind of from a broader perspective, where healthcare inflation is pushing us, what type of program changes or cost control mechanisms are being considered by employers across the country. Again, this data comes to us from our national survey. Let me get right to that one. And this is our 29th annual survey, which is beneficial, but it's, I think more importantly, it gives us a good cross-section of kind of what's going on nationally. So with respect to participants in the survey, it includes many of the providers that LACERA currently uses, like Cigna, Elevance, which is also Anthem Blue Cross, Kaiser, and United Healthcare. So we get a good sense of that. But again, it's what's going on nationally. So the West Coast will be a little bit different and unique in terms of kind of what we're seeing and representing. So again, we'll kind of try to blend in what we're seeing from a national perspective and then weave in things that are, I think, interesting or unique to LACERA. So as we go from there, I'm going to go to the next slide. I love this slide because it's hard to read. I think it's spaghetti. I think we had that reference earlier this morning, so I think I'll live with it and die by it. But I think the interesting part to me is that this is what has been projected. We'll look at a slide a little bit later in terms of kind of what actually happened, but I think nobody's surprised by kind of the change in direction of the chart. Historically, CPI is roughly targeted around 2%. So we're 2 to 3% is kind of what we're looking at. That's the bottom line on in the purple. As we gravitate above that, you'll notice that healthcare and pharmacy costs are typically multiples of that CPI number. So again, we've always been chasing, trying to find ways to kind of manage it down to CPI. And I don't know if we'll ever get to that point. So I think it really becomes a matter of how can we invest in the program prudently? How do we ensure the members have access to the care they need at the right time they need it so that we can actually manage costs and do it at the right time, at the right spend. But 2020, I think not a surprise to anybody, it cratered, right? Nobody had access to anything, whether that was medical, dental, everything shut down. And so we kind of had this block of nothing happening. And of course, then when we kind of removed those restrictions and kind of went back to it, what happened? We had a corresponding spike. So did it level out? No, it actually kind of went up and down and kind of rickshawed. So we, coming out of 2021, we had some spikes. In 2022, we saw some reductions, and even that would be variable. I think one of your longest partners, Kaiser Permanente, has a different pattern. They are a budget-based model system. So they kind of project for what things are going to happen. From their perspective, they reacted very aggressively to the COVID pandemic and built out testing resources and a variety of other things. So while they weren't spending money on surgeries, they were investing in other means of trying to address the pandemic and to help their members stay healthy. So their slide of change would be a little bit different than what we saw from others. But regardless, we've kind of gotten back to kind of what is kind of normal trend. Unfortunately, I think trend right now is that for healthcare, we're projecting costs anywhere between probably around just a little bit over 9% to perhaps more, depending upon each organization's direct experience. So again, putting a lot of pressure on us to kind of keep pace, and as inflation rises everywhere else, that number likely may get pushed up. So it's something we need to consider. The chart here again talks about PPOs, which I just referenced, which is the 9.3%. HMOs at about 8.8. And I think the important thing I want to leave here too is that this excludes pharmacy. This is strictly just looking at the medical component. And as I think we realize, as more and more care gets shifted from inpatient facilities to outpatient facilities, from outpatient facilities to pharmacy treatments, which can be even more beneficial to members. So it's like we're kind of creating new opportunities to treat people and do it in a many times a more cost-effective way. but that progress doesn't come cheap. And so we do see a variety of challenges there. So I'm gonna kind of turn over to Daljeet. Maybe you can give some background on what we're seeing on the pharmacy side.
Sure. So this slide says to me GLP-1s, which has been kind of the story lately. But if you look at 2017, that's when Ozempic was introduced and it was approved for type 2 diabetes. We saw some uptake with that. But then you can look at 2021 where you see that huge spike. That's when Wegovy was approved for weight management. And since Wegovy is basically the same drug as Ozempic, they're both semaglutide, slightly different strengths, but Wegovy was introduced, we started seeing more use of Ozempic as well. Some of it might have been off-label use. There was a lot of social media talk. I don't do social media, but that's what I heard. Lots of social media, lots of Kardashians, the whole thing pushing these drugs. So in 2023, we saw another spike. So I'm looking at that lavender line there, 13.7%. And that was the Zepbound approval, approved for weight loss. It's a dual mechanism, GLP-1, GIP. So we saw another spike. And then we saw the trend flatten out as of 2024. It's been more flat, 10.2 to now about 11% in 2026. And we expect that to continue. With the GLP-1s, there will be additional drugs coming. You've heard of the oral Wegovy that hit the market earlier this year. We expect oligoprofen. I can't say it right. Even I can't say it right. But it's not oligo. Okay, I'm gonna have to look up the drug. But that one is another oral drug that's expected to hit the market. It should have been approved by now, but it's a drug that's gonna reduce weight loss only about 10%, whereas the Wegovy can get up to 21%, or the Zepbound can get up into the 20s as well. So it may be for people that just want to lose a little bit of weight. Maybe they're going to use it in the summers or something just to get into beach shape or something for the beach. But we expect more of these drugs to keep hitting. So more orals, maybe more drugs that can be used once a month. This is a very popular category in the pipeline. So we do expect trend to stay relatively flat because there's going to be more competition in the category. We expect prices to kind of level out. We have seen some biosimilars drop that I'll talk about later before I take up too much time, because I can talk about GLP-1s all day. So I'll pass it back to Steve.
I thought everybody wanted to talk about GLP-1s forever. Why don't we move on to the next slide, and Michael, why don't you give us some background on, I'd love it, this would work for me. Or is it?
Red button.
There we go.
Yep.
My thumb's really fast with my eyes.
Thank you, Steve. For the 26 plan year, the projected PPO trend is 9.3%. It's the highest projected trend in the decade. In the prior slide, those numbers prior to 26 were actual trend numbers. And as a point of reference, LACERA's plans 1, 2, and prudent buyer, this is where we benchmark the medical trend to our 9.3% PPO trend. There's a couple of factors that are driving the trend, specifically price inflation for hospital provider groups and utilization for physician trends. For price inflation, the overall cost driver, it's rising labor costs, regulatory changes, and workforce shortages. An example of that would be in January 26. Kaiser just finalized their labor negotiations with the nursing union. If there was a strike, for that example, if there was a walkout or a strike, those facilities would have to hire traveling nurses, which would compound the expenses. And once those labor negotiations were complete, those overall costs for the hourly or per diem nurses would increase as well, and that would be reflected in those hospital facilities. And as and that would be for the inpatient side of it. As plans are trying to address cost, they're also trying to shift the hospital services to outpatient facilities. So in 2024, the overall trend for outpatient hospital facilities was around 10%. It's mainly driven to more complicated procedures in the inpatient facility that they're trying to save costs and have in the outpatient facility. So they're complicated, they're saving costs, but at the same time, it's those are expensive procedures like knee procedures or hip procedures. And finally, with this secondary factor is the professional expense or the physician expense. In 2022, the expense trend was 1.9% and it quadrupled to 8.3% in 2024. This is mainly due to higher demand in services. How do we catch an early, how can we perform tests to address any kind of early stages of cancer, just preemptive types of services?
So, a little background too. So I grew up in Southern California. I grew up in Torrance, and I spent 15 years in Minneapolis. So when I left, the West Side was basically a mix of different provider groups. UCLA was only in Westwood, and when I got back, UCLA was the entire West Side. And then you looked and said, okay, so what did USC do? They took the entire San Gabriel Valley. Okay, so it seemed like, okay, I guess we're done. I can see now. I live in North Orange County, but now I can see UCI is labeling everything. So again, you can see that. It seems glacial, but the ability to kind of negotiate the contracts with 3 systems instead of perhaps 6 or 7 different provider groups really kind of drives that pricing. So again, we are where we are, and it's a matter of getting the most value out of those systems, but it is kind of like glacial change in terms of there are just fewer providers to negotiate with. And so it really comes down to, all right, who's going to deliver quality? And then how do we get to make sure members are accessing those providers at the right time in the right place?
All right, back to pharmacy. So the projected annual cost trend, as I mentioned, is around 11%, similar to the prior year. The top drivers are things like new therapies, orphan drugs. You've probably heard that before for orphan diseases, which are more rare diseases. There's really been a strategic shift by drug makers to try to make drugs for these particular rare diseases, get them on the market as soon as possible. The FDA has fast-tracked a lot of them. They're very expensive because they are for rare diseases. They're only going to be used in smaller amounts. They won't be mass distribution where the price goes down. So they're expensive drugs. The other things are manufacturer price increases. So Humira, we hear about this drug all the time, multiple indications. It's being studied for more and more inflammatory diseases. It's got 12 indications now and they keep going up, but it went into a biosimilar. So it's not a generic, but it's basically a similar drug because this is a specialty drug. But Humira, the makers knew that the biosimilar was going to be approved. So they kept increasing the prices. I had seen that year over year, it used to be about 9%, and then it became a quarterly increase. So they were trying to get as much profit as they could before it went to the biosimilar market. So the price increases are something. Also, the gains in use of GLP-1s and other meds to treat diabetes, because as we know, more people have pre-diabetes, more people have diabetes, so treatment has increased. So that's contributed to increased costs. So
Can I ask you a quick question?
Oh, sure.
What is the difference between a biosimilar and a generic?
So generics are typically for synthetic drugs made with synthetic materials or even natural materials, whereas biosimilars are big protein molecules. You can't just take them orally because they'll break down in your gut with the acids in your gut. So they're typically injectable products and they have to be made differently. So biosimilars are typically for these big protein molecules, special drugs.
So it's not really a way to get around generics.
No.
Okay.
It's a particular substitution for specialty drugs. So our SHAPE team, which is it's basically a Siegel warehouse of our client data, also does their own analysis. And what they found is for our plans that cover the GLP-1s for anti-obesity, the trend is about 6% higher than it is for the plans that don't cover. So we've still been cautioning plans about coverage because it is still very expensive. So that was an interesting stat.
I have a question too.
Sure.
The GLP and biosimilars thing. So there are tablets now that are GLP tablets.
Yes,
But
there's
then
one.
weren't the GLPs injectable type drugs? So aren't they biologically based? So how does something with synthetic drugs perform similar to the biochemical drugs?
So it's the same ingredient, but they have the way they've formed the dosage, it can be taken orally. So what they did basically is there was a drug called Rybelsus, and it's an oral diabetes drug. And what they did is they studied different dosages to have this new drug come out called orforglipron that I couldn't remember later. So they study these drugs. They try to look at how can we turn an injectable drug into an oral drug. It's all something the manufacturer does. So it can be done. It just takes a lot more study. So initially it was just injectables, the Wegovy, the Zepbound, Ozempic, all injectable. But now the manufacturers have had more years to study and they're bringing more orals to the market. So they've been able to show that although they're taken orally, the way they're forming the tablet, it doesn't break down in your gut and it's efficacious. It reaches levels in your bloodstream that actually work to the same, almost the same degree or more than the injectables.
What about the side effects that might be caused by this?
Good
Has there
point.
been enough study on that?
Yes, so the oral Wegovy, there are cautions about you should only drink it with about 4 ounces of water, and you should keep it away from other meds by at least an hour before, 2 hours after. And it does cause more gastrointestinal effects because it is taken orally. So people just have to try to manage those. So there may be people that say, oh, I'd much rather just inject my Wegovy than take this oral form. It just doesn't suit me. So we may see people that will not move to the oral, but for most people, they're going to at least want to try it because it's just easier, or they don't want to do the injection.
Thanks.
I guess part of what's interesting to me is I don't recall hearing the terminology biosimilar 5 years ago. Did it exist 5 years ago or I wasn't aware of it, so.
Yeah, I think the first biosimilars hit, time's going by so fast that I can't even track it well, but it's probably been 20 years or more.
Okay.
But there were biosimilars for, if you remember the drug Lovenox, that's an injectable blood thinner. They'd usually give you after you've had a surgery, when you leave the hospital, and then you transition to the oral blood thinner. So they started with some of those. There were just a few, and now there are more and more coming down the pike.
It seems to me that it's just part of the changing landscape of prescriptions of medications right now. We seem to be a lot more biosimilars out there that we're talking about than even 5 years ago.
Yes. So we've had the pipeline for specialty drugs, which is where most of the biosimilars are, they're copying those drugs, has greatly increased. And I think there are about 700 specialty products that are supposed to hit the market within the next year or so. And then they're studying over 2,200. So there's been a big pickup. And the primary reason is that because the way these drugs are made, and a lot of them are injectable, and like I said, they're big protein molecules that are very fragile. A lot of them have to be refrigerated, and they're distributed by special pharmacies. But they can be more efficacious. I remember the day when I was in pharmacy school, and they said for psoriasis or for some other eczema, people have to take these oral drugs, and they were really awful drugs. You know, the toxicity levels, the side effects were just horrible. And then when Humira hit the market and some of these other drugs, Enbrel, people started using them, the efficacy is much higher and they're so much easier to take. So we fought the battle for a long time saying, no, you have to try these oral drugs first. And then it became that we really just saw that they're so much more efficacious. Why put people through the orals if you don't have to? So these drugs work.
Can we go back to GLPs for a minute? Are there long-term studies about whether they are unhealthy, what they cause, whether they actually are good for you? I'm hearing that also.
I actually thought the same thing, but they've been out for over 20 years. The first few there was Victoza, I mentioned Rybelsus. There were a few of them that came out 20 years ago, and we've been using them. And there haven't been really any untoward long-term side effects that they've seen. Everything so far has been beneficial. Hopefully nothing pops up later. I know with certain drugs, I don't know if you remember Vioxx it's an anti-inflammatory, and it was years and years later, like a decade later, that it was taken off the market because it had a long-term side effect. But it was something that the manufacturer held back. But these have been studied by so many different manufacturers that, knock on wood, nothing pops up after 20 some years.
Mr. Chair, if I may, I have a question. These annual increases in double digits, right? They're showing in the prescription medicines, combined with, increase like you discussed with the contract, increases in pay. We have our fringe, right? That typically, on a 3-year cycle, does its best to keep up with the increase in the costs. Remember that regulation on insulin with the that someone was trying to really spike that up there, and I think there was media pressure and everything else. Is there any regulation that is, because at some point, right, it's potentially could tip, and I'm thinking more of our pensioners that are subject to a cap, as these costs go up. And I know we're working on trying to lift that cap entirely. The Affordable Care Act, you guys know the sick joke is that there's no cap while you're working, but there's a cap when you retire, when you probably need, medical treatment the most. So is there any legislation that's out there to regulate this? Because these are significant numbers, And if the contract negotiations for our fringe package don't keep pace with that, potentially, it's more out of pocket cost, just to have insurance, and then, or it could force somebody, and then the second part is, of course, like you said, some of these drugs could be extremely expensive that they have to take all the time the rest of their life. So
yes. As Amy mentioned in her presentation, I don't know if you're here for that, but they're definitely, legislation is what we're counting on. We know that the PBMs are keeping a significant portion of rebates, and that's why the transparency legislation is so important. They have formed group purchasing organizations in other countries, and what happens is in all the contracts, they say, we're going to keep these manufacturer administrative fees or these other fees. So they don't pay, even though they say we're paying 100% of rebates, it's not 100%. They're holding some money back. So these transparency laws are very important, especially when we're talking about drugs that are, $10,000 a month or $100,000 a year, or drug costs continually go up, especially when we've got specialty drugs that I know the manufacturers are spending a lot of money studying them, and they want to reap the benefits of that by selling them at high prices. But with legislation like the most favored nation, where most countries have drugs that are cheaper than in the US, and with the transparency laws, that should hopefully make an impact.
yeah, and on the spaghetti chart, there was occasions that it trended down. And is it strictly connected with the CPI? How is that relationship, or is it just never going to go down?
To be honest, I don't think it'll ever go down. I think, as Daljeet pointed out early on, the introduction of new medications is where those spikes occur. Because not only it's an alternative treatment for something that exists. I think, as you were just pointing out, there are different drugs, but the new drug costs more, but the outcome is improved. And so it just shifts everything upwards. So it doesn't replace anything. It's just we're trading a lower cost treatment for a higher cost treatment, but with better outcomes.
And that's what you're demonstrating here with the AOM absent. It's 9.2, but then 14.8. Yeah. Wow. All right. Well, if we need to lift the cap.
So these are just a overall list of factors that impact trend. For LACERA with their retiree population, the one that sticks out the most is the aging population, with the rise in obesity, and with obesity, there's a prevalence of heart disease, diabetes, joint inflammation, and these are all categories of chronic conditions for the members. And as a result, over years of utilizing health services, it just drives the trend up. And another one that's also prevalent is the erosion of the fixed deductible and copayments. A lot of LACERA's plans are grandfathered. So for example, the non-Medicare Kaiser HMO plan, no deductible, and for a lot of services, it's a $5 copay. So as medical trend increases, for the PPO, it's 9.8%. For the HMO, it's around 8%. As they increase, the totality of that cost it's still going to grow. But those claims, the member's going to enjoy the benefit of the $5 copay, but that cost is going to be shifted towards the carrier and then eventually towards the renewal cycle.
I'll just add to that we see a lot of new treatments for cancer. It's for most of our clients, cancer is in the top 10 drug therapeutic categories as far as costs are concerned. So it's a positive that we have all these new cancer drugs treating certain rare cancers, but it is a cost. At some point, I do see the PBMs taking a look at, should we cover a cancer drug that extends life 6 months or 10 months? How much is that worth? So there are going to be some ethical dilemmas involved in some of this as the PBMs try to navigate which drug do we add to the formulary in certain categories.
Thank you, Daljeet. So all the numbers we talked about have been kind of what I would call in aggregate. It's what we expect to see on a broad basis. But each individual plan sponsor goes, okay, but what about me? Okay, I see what the trend is, and we always want to be just below trend or whatnot, but it's like some years we're above, some years we're below. There are multiple factors that impact this. So this is kind of a cross section of variety of strategies or impacts that will influence what your overall renewal looks like. So the prevalence of high cost catastrophic claims. So Daljeet just mentioned the treatments for oncology. Fantastic advances, but they do come at a price. LACERA currently is moving or working towards moving that Anthem lifetime maximum from, I think we're at 1.5, and we're trying to strategically get it to an unlimited basis. So I, again, applaud everyone that's had a hand in that to get us where we are, because it's true. As members incur these expenses, they're going to brush up against that threshold much more quickly than perhaps they would have in the past. And again, I think, not jokingly, but kind of the basis of your plan designs are based on what was in existence in 1982. Okay, there's no product on the planet that you would want from 1982 if you could have something as of today. So the idea is, what do we have to do to kind of manipulate the plan designs or whatnot to, one, be good fiduciaries, kind of protect the resources that fund this program into the future, but also provide members access. So again, I think continually working towards trying to find ways to accomplish that. So again, I applaud everyone that's worked on this to date and the progress that's been made, but it is important. I think we take it very personally too, that our job is being an extension of LACERA and trying to serve your membership. So if we can find ways of incrementally changing a lifetime maximum, then we have a shared goal. Plan sponsors across the country, and again, this is a mix of active employers, retirees, et cetera, use a variety of different cost management programs. So for instance, your copays under the pharmacy benefit have been kind of locked in the beginning of time. They don't change. So Michael said a moment ago that over time, the value of those copays erodes. It really costs the member less and less each year because that copay is fixed relative to the expense. So it's like, how do we try to find ways of kind of managing that? So partnering with CVS and Anthem and others, there are different approaches that can be taken to manage the introduction of new medications, just to make sure they have the desired impact and, advantages to the members. So things are going on behind the scenes that it's like your plan never changes. That on its face, that's true. But there are also efforts being made by staff and others to kind of ensure that your programs are being kept up to date, staying in pace with kind of what's best in class and best approaches to ensure access, but at an appropriate cost. Probably one that I think it's historic, but it still resonates with me, is that your plans are what are called indemnity plans. Okay? Just means I go to the doctor, I pay a fixed percentage, plan pays the other fixed percentage, and we're done. That's kind of how it worked. That was before 1982 and kind of goes back in the Wayback Machine. Where we are today are a variety of plans, PPO plans. You know, if you go to contracted provider, you'll get the benefit of the discount. It'll reduce your out-of-pocket expense. It'll help stretch the plan dollars further for the plan sponsor. Okay, that works. How does that work with an indemnity plan? It shouldn't. But the staff here, I think, did an incredible job of trying to partner with Anthem, as an example, said, you have one of the largest networks in California. For other clients that we serve, probably 90 to 95% of all claim activity occurs in network, but you weren't able to leverage that. LACERA staff managed to work with Anthem to set that up on a passive basis, so it doesn't negatively impact the member at all. They continue to see services from who they wanted to see it from. Claim gets processed, but instead of processing it kind of the retail cost, you're getting the benefits of that negotiated discount. So again, there are things that staff has done in concert with the board to kind of make this program as efficient as possible, and will continue to do so. The next one is choice of provider networks. This is probably more akin to what I would say east of the Rockies. It's my bias. I'll take that one. But when I left here, went to Minnesota, I thought I'd know everything. I thought I did. And I got there and it's like Minnesota was completely different in terms of healthcare because each region of the country practices and does things differently. Wisconsin's nothing but valleys. And there's a different health plan in each valley. Can't be more inefficient than that. But in terms of provider choice and network, you partner with Kaiser and you partner with them for decades. They've been a good partner, but I would put that at kind of the pinnacle of a tightly managed network. So again, you're leveraging things that don't exist in other parts of the country. And so again, a benefit to both you and to the members. In terms of appropriate plan design features, again, there's a variety of things. I think it's probably the easiest one to offer would be, we talked about the pharmacy copays being fixed. But your plans for regular medications, 20% coinsurance. That's what the member's paying. If the member is on a maintenance medication, staff has worked with CVS to create options so that members who want extended dosage, like over 90 days, can get it at a copay. So again, there are trade-offs for things that make that work. Probably the ultimate was the introduction of the Medicare Advantage plans. All right, when they were introduced, it's an indemnity plan. It only is going to cost more over time. So by adopting the Medicare Advantage plans like Kaiser Permanente Senior Advantage Plan, United Healthcare's Medicare Advantage Plan SCAN, you're able to tap into federal resources that subsidize those plans and brought down the overall cost. So again, working in partnership with the county and saying, we have a solution that benefits everyone. And by working together, you're able to adopt that and implement it. So again, tremendous work has been done historically. We'll have to see what the future portends for us in terms of what else we can take advantage of. But by no means should you walk out of here thinking 82 contract, our plans are passive. We're just kind of trying to let the county carry the burden. That couldn't be further from the truth. I think you've been very proactive in what you've attempted to do to manage this overall program and extend the value of it into kind of well into the future. Going to do this one more time, and it's only because the chart we showed before was a combination of kind of projected and actual. This is kind of like what actually happened. So I look at this and having done this for, as Cassandra was kind enough to point out, a couple of decades. These initial projections are estimates, right? They're kind of saying, okay, a year from now, this is what we think we're going to spend. Sometimes they're accurate, sometimes they're not. Coming out of COVID, everybody thought it would be kind of through the roof again, but it took time to get there. So the projections early on were overstated. They balanced out over time. But as you can see, we're still, again, just if we're using CPIU as the benchmark, we're still a multiple of that. And that's, again, not going to change. I'm going to turn over to Michael to give us a little insight into kind of what we do think is going to be happening kind of over the next 12 plus months.
Thank you, Steve. So these graphs, these charts, they project the medical trends for active and non-Medicare retirees. Overall, there's an uptick in the trend for all groups: high deductible plans, PPO and POS plans, HMO and EPO plans. There's been pricing pressures, as we discussed earlier, related to hospital trends, physician trends. And just as a point of reference, the PPO plan is we would benchmark those trends to the Anthem plans 1, 2, and prudent buyer. And for the HMO plans, we would benchmark that medical trend to LACERA's Kaiser non-Medicare plan, United Healthcare non-Medicare plan, and the Cigna network model plan. And these are the projected trends for the projected medical trends for the Medicare retirees. For the Medicare Advantage PPO and the Medicare Advantage HMO trend, it increased from 4.9% in 2025 to 6.2%. There's a lot of factors to it. Historically, Medicare Advantage plans have been more affordable for retirees. So historically, year over year, you'll see increased enrollment. However, in 2024 to 2025 and projected to be in 2026, the health insurers that offer these Medicare Advantage plans, the utilization overall claims experience has increased. So there's been pricing pressure. Additionally, CMS has been changing their reimbursement schedule to favor the traditional Medicare plans to kind of even out the playing field because there's been so much more enrollment in the Medicare Advantage plan. And lastly, the Medicare Supplement Plan, the 2026 trend increased by is projected to be 7.7%. This, as a reference point, this would be most similar to LACERA's Plan 3. While the Medicare Advantage Plan enrollment increased, the Medicare Supplement Plan enrollment either stagnated or decreased. This plan offers members a more passive network. There's less restrictions in terms of the type of provider you want to use as long as they accept Medicare. So there is an element of adverse selection, but yeah.
Thank you. All right. This is it's just a snapshot from January 22 through December 2024. I probably feel obligated to show some sort of actuarial presentation because we're an actuarial firm. Basically, I think what the story comes down to is, again, what we project to have happened. Because again, every renewal we work on with LACERA, we're projecting out basically 18 to 24 months before the end of that plan year. So again, things are going to happen. We're going to have different claim activity. There may be new legislation. There could be a variety of things, but basically the numbers we've shared so far in terms of trend are kind of like anticipated what's expected. This chart kind of looks at kind of our SHAPE data warehouse and says for the plan sponsors we have in this database, they all ran the gamut anywhere between kind of the 25th and 70th percentile, and somewhere in there is that line. Well, in terms of one of the cost drivers that I think is continuing to emerge, and again, I'm taking this from the perspective not specifically LACERA, but nationally, is the increase in mental health treatment. So what we're seeing across the country is, kind of coming into the pandemic or just ahead of it, there was some increase in utilization, and that has continued to increase over time. I think from a variety of standpoints, we're kind of looking at the top trends and conditions, and we're looking at treatments for autism, attention deficit disorder, trauma, stress, anxiety, et cetera. So it's like, okay, that makes sense. You look at that chart on the far right, year over year, it's like, okay, we're heading towards double-digit territory. None of that is inherently a bad thing. Again, if we're getting treatment, if you look at it holistically, someone may be able to address a condition or an issue, and that may longer term actually hold down or moderate what their medical costs could be in the future. So again, that's a positive. I think what stuck with me is I came across this a couple weeks ago, and it just struck me as odd, is that from a healthcare standpoint, again, we talked about mental health increasing across the spectrum. Where we don't see it increasing is in the 65 plus. Okay. Again, whether that's stigma or not, you can see that the balance is really weighted towards kind of the younger age groups. But that's not to say that there may not be needs within your population that could benefit from kind of those types of services. So I would say that we probably look at this kind of in the future as an opportunity to kind of ensure members are aware of how to use this resources and how to do that going forward. I'm going to turn it over to Daljeet.
All right, so turn on the mic. So here, we've talked about this already, but basically specialty is driving trend, as you know. It dropped a teeny bit in 2026, and that's probably because of the biosimilars for Humira, and that'll continue to help reduce costs because it's such a popular drug. It's usually in the top 10 for most clients because it has the 12 indications for different disease states for use. So I think we looked at this before, not to belabor the point, but it's GLP-1s and specialty drugs driving the trend again. And we saw that it's closer to about 11% since 2024. So I'll jump to, I don't want to steal the thunder of the people presenting the GLP-1 discussion or the panel discussion later, but I already mentioned on this slide, the 6% higher for plans that cover obesity, and then I'll drop it back to Steve.
We'll hand it off to Mike.
Thank you, Steve. So we have the projected dental and vision trends for 2025. For the dental plans, the year-over-year trend remains relatively flat. However, there are some cost drivers for dental trend, operational cost, materials, crowns, those increase every year, billing, overhead, lease. However, the major major factor that's driving the dental trend, it's related to the shortage of workforce labor, specifically hygienists. It dipped in 2020. A lot of hygienists retired and it flatlined, but it never met the needs for dental services. For the vision trend, the year-over-year trend remains relatively flat. It may basically due to how the services are provided. You usually get one exam and you purchase materials one time a year. So.
Thanks, Mike.
Real quick, Cassandra, Delta Dental, the county has, what on that chart, what is it considered? Or the Delta?
The retiree dental?
No, both of them, the Delta, the plan that we could for choices, the Delta Dental, what is that? Which one is that? Could you go back real quick if you don't mind? On that, is it a DPO?
Oh, the one through the county?
Yes.
It is a PPO.
A PPO.
Mm-hmm. The similar to our retiree healthcare options, we have both a PPO option as well as an HMO option.
And so that would be under this chart, a DPO then?
Mm-hmm.
Okay, thank you.
So again, trying to kind of identify the silver lining, but it's like, what else is going on where we have challenges, where are the opportunities being created? Very quickly, digital health coaching. Think about the continuous glucose monitors, which members can wear, kind of track on their phone and help them kind of manage situations so their A1C is kind of within the right spot. Well-being services could be kind of a very broad category, but as an example, Kaiser Permanente offers both Calm and Headspace at no cost to members to help them kind of manage a variety of things, whether that's anxiety, stress, sleep, mood, etc. So again, there are embedded resources within the plans that members have access to that they could be using. I'm going to go to the next slide and just kind of talk on AI, given that yesterday was AI, so I don't think we could have any time without a little bit of AI here. But I think the important part is that I think all cares, whether it's Anthem or some of your other partners, are actually trying to kind of look at the claims data and to some extent try to project which members might be incurring expenses or be trending in a manner that would say we could probably predict within the next 12 months that they're likely to have kind of an episode that might require hospitalization or a variety of other things. So they're trying to look through the data, trying to understand who those members are and see what they can do to kind of close the gaps. And so here's kind of a linear snapshot of kind of what Anthem might do, looking at, again, the data, following up with members after hospitalization to get a sense of kind of where they're at. But also looking in real time, what do the claims say, ER visits, referrals from providers, but also reaching out to the member to get a sense of where are they at, where kind of what's in their headspace right now, and how do we help that. But again, really looking to develop or identify through clinical assessment who might be a suicide risk, who might be at risk for substance abuse. So it's like, can we get ahead of that curve by trying to understand that? You know, that's all well and good, but again, it still requires kind of the human touch. How do you take someone that you've identified and saying, I think you're at risk, but help them kind of visualize that opportunity as that moment to say yes? Because without that, we're still kind of chasing that member. But again, that's how your partners are trying to help you and your members access care and get it at the right time, at the right price point. The next one, thanks for the segue regarding dental. Couldn't have planned that any better. But I think, again, kind of relating to yesterday's discussion about LACERA's evolving app for members. How do they do that? I think found what interesting is that Cigna, amongst your partners and nationally, was actually ranked as the #1 app for healthcare across the country amongst their peers. It was kind of very interesting because I don't worry about that stuff too much, but it's nice to hear it. But this specific exhibit actually gives us some insight into how members could access data, both from background on the clinician, education, specialty, other experiences, real patient references, et cetera, to give them a sense of how that's going to work, and also projecting what the cost might be. So it's like once upon a time, I was like, go get a pre-estimate of what the service might be, and you go and you get it done, and may or may not match. This is really going, if you go to Dr. A versus Dr. B, I know what the price point's gonna be. So again, that's a lot more certainty for the member. The interesting challenge for me, and I think where this is an opportunity, is that approximately 35% of dentists that are currently delivering care today expect to retire in the next 5 years. Dentistry is one of those areas where once you find someone that you appreciate and want to be with, you never move. I don't care what changes we make to design or networks. It's just, is my dentist in that network? It's a rock solid relationship. But we're getting to the point now where 35% of all dentists are going to retire in the next 5 years. So we're going to have many members and individuals going, I've been with someone for 30 plus years. What am I supposed to do? Okay. The tools are evolving. It's just a matter of making sure members are comfortable and can take advantage of that. So again, opportunity that's coming up, and we'll see how members can take advantage. LG.
All right, I'll talk about these more in the coming slides, but effective clinical controls, it's been the same things for years and years. Utilization management tools like prior authorization, step edits, quantity limits based on FDA approved dosages. With specialty cost management, it's getting a little more tricky, and we're trying to figure out more strategies so that we can get biosimilar usage up, bring costs down, and then strategies for GLP-1s are constantly evolving, including direct-to-consumer carve-outs. So utilization management, I know you're probably all familiar with this, but all PBMs have basic prior authorization for certain drugs that are not first-line drugs. They have people use those first-line drugs and try them before they can use the drug that the doctor has to get the prior authorization for. There are formulary management strategies. What you have in place now with CVS has an additional layer, which is the Advanced Control Specialty Formulary, which manages formulary drugs separately from specialty drugs, separately from non-specialty drugs. They're one of the only PBMs that do that, have a totally separate formulary for specialty drugs, which is good. And then clinical programs, you've got quite a few in place now. Drug savings review that they do, looking at drug claims retrospectively, identifying things that can be changed. And then an accordant care rare program to help people that have rare or complex diseases. So pharmacists and nurses engaging on the specialty side to help members with the drugs they're taking. And then the pharmacy advisor counseling, which is also extra counseling for certain disease states. So you've got all of these tools in place, which are great. What we've seen is the promotion of biosimilars. PBMs have taken different directions on these, and not really happy with that right now. I want to see when a biosimilar comes out, put it on the formulary, exclude the originator drug. Let's get the prices down immediately. But what a lot of the PBMs are doing are they're still playing this rebate chasing game where they say, we're still going to cover Humira because the rebates are so high, it actually brings the cost down lower than the biosimilar cost. But it's just like when the generics came out. They wanted to cover some of the brand drugs and keep the rebates instead of going directly to the generics. So we always want our strategy to be low net cost, but it'd be nice to take the rebate factor out of this. And hopefully the transparency laws will help.
What about the idea that there are just some people, I'm one of them, who likes the brand drug?
Yeah.
I don't want to use biosimilar. I don't want to use generic. I hate generic. I mean, on some medications, fine, it works fine, but there are really some that don't work the same. And I was actually startled just now earlier when you said that they're synthetic. I don't know if regular drugs are synthetic, but if it's a synthetic version, no wonder it isn't the same. And I have got into fights with my doctor, and I'm not even retired yet, fights with my doctor that I don't want the generic. It doesn't work the same. And she's like, it's the exact same thing. And I keep saying, no, it's not. It's just not. So what about that?
So when I was working retail pharmacy, I used to have the same argument with patients all the time. But then I realized, people react differently to drugs. When they do clinical trials, it's 1,000 people. When you give it to the broader population, you're going to see differences. I actually tricked my mother because she's like, only brand name Advil works for me. I was like, no, Mom, you do the ibuprofen. I snuck her, I switched out her drugs, and she didn't have the same effect with the Advil. She just didn't. So what I realized is with the FDA allows, when they do the approval for a generic, there could be a 10% variation in the bioavailability, which is the amount of drug in your bloodstream, a 10% difference, which is pretty significant. So for some people, if a generic is 90% of the bioavailability and the brand is 100%, that 10% difference is going to be significant. So I will say, yes, for some people, for a small amount of people, they can just they need the brand drug. And that's why when generic estrogens or generic thyroid pills hit the market, or even seizure drugs, I like people to stay on one or the other, because you're going to change your blood levels when you go from one to the other. So we're very careful with that. Lately, the PBMs have had strategies to get people off of even thyroid hormone and get them on generics, and they stay on the generic and their blood levels tend to stay the same. So it hasn't been a problem. But I will say that in specific cases, some people need to take the brand drug. With specialty drugs, I don't think it's going to be as big an issue just because the way the drugs are made. Like I said, it's hard to explain, but they're big protein molecules. They're studied very intensely. A lot of them are being made by the same companies that make the originator product. And that's happening with generics too. A lot of brand companies started making their own generics. The generic even looks the same, has the same markings as the brand, because they just put it in the other bottle. So it's gotten very interesting, but I don't think that should be an issue. And with most people, they're switching to biosimilars. There's been a bigger migration of people from brand to generic. When we look at people's clients' generic dispensing rate, the GDR, it's gone higher and higher every year. So fewer people are fighting the change. And we see less and less of the DAW1 where the doctor writes on the prescription, dispense is written, seeing less and less of that as well.
So can you tell me a little bit more about the meaning synthetic, and whether that really means synthetic, like I'm thinking synthetic?
So most drugs are made synthetically. There's a chemical ingredient and they're studied and made synthetically. There are some natural drugs like digoxin comes from willow bark, or aspirin comes from, and I may get this backwards, aspirin comes from a natural ingredient. The American Indians used to chew on certain things to get the natural effect. So some drugs are natural, but most drugs are synthetic. They're man-made from chemical ingredients.
So that's whether it's generic or
correct.
Regular.
Correct. It used to be that, not to talk too much, I know we're over time, but Premarin, the estrogen, the brand name, it was made from horse's urine. So they would extract the estrogen from horse's urine. And I think if the drugs are still around, they still do that. But that's where it came from. Whereas the generics were synthetic versions. They were man-made versions of estrogen. So the same chemical compound, but man-made.
Okay, and one last question. I'm assuming that when you retire and you get into disability healthcare, for example, there's still a PPO and you can still go through getting your medication without needing a prior approval, or like you do with a PPO that's not retirement related.
It depends, I believe, if they have a workers' comp case, whether they've taken a settlement, those drugs would be covered under that workers' comp case as opposed to their retiree medical.
Okay, but for the regular person who doesn't have a workers' comp case?
Depends on the drugs, then they would have to go through a prior auth.
But if you don't have to go through it, I mean, are the rules the same is basically what I'm asking. If you have to go through it before you retire, you have to go through it after. If you don't go through it before, okay,
Yes.
Thank you.
All right, I'm gonna try to wrap it up quick now. So on slide 27, I just wanted to mention biosimilars for Stelara. It's another drug that has been around for a while, and now there are 8 biosimilars. There are 3 that are interchangeable. So what the PBMs are doing is they're putting the interchangeable ones on the formulary, which is great. That means that a person brings in a prescription to the pharmacist for Stelara. The pharmacist can go ahead and change it, just like they would for a branded generic. If it's marked as approved as interchangeable, they can make the change right at the pharmacy. They don't have to call the doctor, saves time, saves aggravation on the members' side. So that's a good thing.
Daljit, real quick.
Yes.
Daljit had just mentioned about Humira. I know with our Anthem Blue Cross plan, we have the CVS pharmacy. They were able to successfully move the members that were under Humira to the biosimilar, which was a less costly drug to help them.
So on the next slide, great thing you're doing here is you're managing the GLP-1s. As of 2023, CVS brought forward an edit that looks back in claims history for members. When they go to the pharmacist is processing the drug, looks back in history for other diabetic drugs. And if there is a diabetic drug, then the claim will process. It recognizes this person has diabetes, or if there's a diagnosis code, which is less likely, that says this person has diabetes, the claim will pay. So we're trying to make sure there's not off-label use, that these drugs are being approved just for diabetics, which saves you money in the long run and ensures appropriate use. And I think we can skip over accordant care just to get.
Good. Thanks for your time this morning.
So for this next presentation, you have Ted Granger, our Chief Financial Officer, as well as myself. We'll be presenting on providing an overview of the retiree healthcare operations fiscal, the retiree healthcare program fiscal operations. So during our overview, Ted and I have 5 key areas that we'll be focusing on. I will skip this because I'll go into more detail on it, the next one. So under our executive summary, I'm going to start with our program foundation, just a little background of our 1982 agreement that we always hear about. That agreement was made back in April of 1982. And what that agreement did, basically, the county agreed to take over the funding of the retiree healthcare program. In that 82 agreement, however, at that time in 1982, it indicated that so long as the county offered healthcare to the active employees, they were to continue providing it to the retired employees. So that was the one key thing in that 82 agreement. What that 82 agreement also did was it froze the benefits to what those benefits were in 1982. So that's why we have such a difficult time where a lot of plans will change their co-pays, change their deductibles. We're unable to do that. So we have to find other ways to try to maintain and manage cost. In 1994, we had the first amendment to that 82 agreement. And what that amendment stated was if the county stops offering healthcare to the active employees, they are still responsible and have to continue coverage for the retirees, survivors, and their eligible dependents. So that was the major difference between the 1982 and the 1994 agreement. I think I kind of got a hit. So these are the things that I just talked about. Our county subsidy, under both agreements, the county is still responsible for paying 4% for every year a member completes with LA County, normally up to 25 years. Once the member reaches 25 years, they get 100% subsidy. However, with the increase in the rising cost of medical benefits, we are starting to see some of the plans that are exceeding that benchmark, and therefore the members with 25 years are now having to pay a portion of that premium. So the second area that I'm going to be covering is our annual workflow with the plan sponsor. We're looking to memorialize and document so that the plan sponsor knows what to expect from what time. But what that does is also it documents our process. So then that way we have the documentation and the county will know what to expect, when to expect, and anticipate changes. So we will avoid areas such as what we had a few years ago where we wanted to increase the admin fee. The county will be able to kind of look and see, looks like we're starting to reach that admin fee. We might anticipate an admin fee increase coming in the near future. So our existing components, as you see on the slide, we have an annual insurance premium renewals, which your board, your committee and board approve in the February, March timing. We are still pursuing the lifetime max increase, successfully getting it increased effective July 1st of 2026 to 2.25. We will continue to try to get that annual lifetime max removed totally for the retirees because that's when people need their healthcare the most. We'll look at documenting the budgeting process again, as I mentioned, so the county will know and can anticipate that there may be increases and we may be coming to ask to increase the admin fee or look at our budget and, far as the healthcare so they can anticipate how much they will be responsible for paying for the healthcare program. Ted will go into more detail about the financial accounts that are retiree healthcare related. That those accounts, I think, come up to an asset amount of over 6.1 billion. And then we also have our reporting requirements, such as the financial and actuarial reporting, which Ted will get into a little bit later. But as I was mentioning, we have proposed additions. There's some that's coming up that Ted will be addressing as far as the OPEB trust and the investments. Again, the program reporting with level changes and financial actuarial reporting modifications that are being discussed, and then funding updates that we're looking to discuss with them. Not yet. Ted's anxious. So on this slide here is the timeline for our annual renewal. Siegel will, our healthcare consultant, I should say, will begin the process normally September, October. That's when the solicitation goes out to our various health plan partners, letting them know that we want to start receiving those proposed rate changes that will be coming up for the upcoming fiscal year. In November, December is the timing when our vendor partners will submit their proposals, and that's when the negotiations start back and forth. We have an all-day carrier meeting that takes place in January. Those are for the final and hopefully well negotiated and the final number that is presented to us in January. So we know that come February, March, we can now provide that information to our committee and or approval to the board for final approval for the July rates at this point in time, being on a fiscal year. During the months of April and June, that's when we're working currently. Like now, we're working on the communication that will be going out to our retirees. That communication will be going out this Friday, May 22nd. We usually do it over the Memorial Day weekend, so there's that 3-day weekend. So when we come back to work that Tuesday, retiree healthcare staff will be ready to take those calls. So we tell them to get plenty of rest over that weekend. And Ted, here you go.
Great, thank you. And thank you for having me and letting me talk about accounting and budgeting to this group. I did want to make one comment relative to the last conversation and Steve's comments to the board. There, of course, advances in technology and science are fantastic. It does offer a little bit of a double-edged sword per se. So I was looking at Milliman's risk assessment report last week. It's going to go to the Board of Investments next month. And in that report, it talks a little bit about, well, if retirees live a little bit longer, we're okay on funding. Generally, it's not a huge risk. However, if there are advances in medicine like cancer drugs, it could cause a problem in the program's funding, essentially. So it's you guys are doing a great job on at this board and managing that. And of course, we want those advances, but we'll have to talk a little bit more about to the Board of Investments about funding the plan should there be significant advances in drugs and life expectancies. So anyway, okay, so I'll talk a little bit about the budgeting. We have two things going on here. First of all, acronyms, RHC, Retiree Healthcare Program, OPEB, Other Post-Employment Benefits Program. Unfortunately, the accountants had to come up with their own term when they issued the new GASB standards back in 2012, 2013. Actually, that was pension. About 2017 was OPEB. So those terms in my mind are interchangeable. So RHC and OPEB. Retiree healthcare budgeting. This is Cassandra's budget. I'm talking about the sort of left-hand side of the slide. That's the $13.8 million that she's asking for next fiscal year, 37 positions, no increases in staff. And that is the budget whereby we're adding the $8 to the premiums, right? Each medical premium has an $8 charge. That $8 funds Cassandra's budget, essentially. One anomaly there, though, is it's costing us a little bit more than $8. It's costing us about $9.69 is our estimate. So in terms of funding that, and we've talked with the county, as Cassandra mentioned, a couple of years ago, and the county said, well, we still like the $8 because the county actually funds a lot of that money through the county subsidies. When they subsidize the insurance premium, they're also subsidizing the administrative fees associated with those plans. So the county said, well, what money do we have on reserves? What money is in the program that we could use to help fund that administrative fee without raising it? And we said, well, we do have some money in the administrative fee account. I'll talk about that in a minute. And so we're drawing down that account, the administrative fee account. So the county's giving us the $8 and we're drawing a little bit, $1.69 per se from that account to the tune of about $1.5 million per year. So again, Cassandra's budget is $14 million, $13 million in the reserve. We're drawing down a little bit of that money to fully fund Cassandra's budget and pay her people to run the program. One quick note, and Cassandra talked about this briefly, we did engage Milliman, our OPEB consultant, to help us look at projections for the administrative fee. We said, oh, Milliman's good at projections, right? They're actuaries, that's what actuaries do. And they did a very, very good job. They did a deep dive into every element of the administrative fee. They broke it down. I think there's about 8 different categories: salaries, benefits, projection of vacancies and when they'll be filled, projections of people retiring for Cassandra's group. Again, it's not a huge group, but so we're going to use that in our discussions with the county in terms of going back to the county and talking to them and saying, hey, we think these are the projections. These are good numbers. Let's talk about the fee increases and get a little bit more grounded in terms of what they want to do and what their philosophy is going to be going forward. So that was the idea there. Real quickly, OPEB trust. So there's 2 components of budgeting for the OPEB trust. This is the pre-funding that the county has set aside. And actually there's 3 employers, the county, LACERA, the court. There's a budget to administering the trust. So for example, Ted is a pension fund employee. However, Ted spends time working on the OPEB trust. So there's an allocation of hours. That's the administrative part. The investment team, the legal team, the accounting team, we work on the OPEB trust. So we budget about $1.2 million for those administrative fees. There's a non-administrative fee component to the OPEB trust. That is the investment management fees and custodial fees. Those are charged directly to the trust. I don't like to project non-administrative or investment fees, but in 24-25, we spent about $10 million on the OPEB trust. So we do provide those budgets to the county for them to review. Let's go to the next slide and see what we have here. Okay. So this is the way we're breaking down sort of the accounts. And it was interesting. We did have AI help us a little bit with preparing these materials. And I thought, and I think John Grable does a great job when he addresses the Board of Investments and he talks about the pension fund and he talks about the OPEB trust. But I never really sort of added it up in terms of the RHC and the OPEB trust as AI did it for us. So 6.1 billion. The bulk of that, of course, is the OPEB trust and the pre-funding, the 5.8 billion. That's a March number. It is consistent with John's number. By the way, I did double check that. And again, OPEB trust participants, the county, the court, LACERA, the outside districts are small and they have their own mechanisms for funding their OPEB obligations. A couple of quick interesting numbers I wanted to throw out in terms of the, if you don't recall from the 2025 OPEB valuation, county's liability is about 26.8 billion. They have about a little over 5 billion, almost 6 billion in assets. Unfunded liability is about 22 billion, again, unfunded. The funded ratio is about 19%. That's for the county. And that kind of represents the whole plan because the other two employers, LACERA and the court, are a little bit smaller, but I'll go ahead and provide their numbers, those numbers anyway. 91 million is LACERA's liability, 30 million in assets. And so it's about a 33% funded ratio. And finally, for the courts, about a $1.1 billion liability, $106 million in assets, a little bit lower number. So they're about 10% funded. So just wanted to kind of provide those numbers for the OPEB trust. Couple of quick accounts that are interesting on this chart. The RHC program, the OPEB program, is its own separate program from pension. So it has its own sort of little ecosystem. And some of the things, because it's not pension, because it's OPEB, there's different accounts and different things we do to administer the program. Let's see, reserves. So about $200 million in reserves. Those reserves are essentially overages from premiums. In other words, the premiums are paid to the carriers every month during the year. When the claim costs are lower than the premiums, the carriers give us rebates. We put that money in this account. Also, when the claim costs are higher than the premiums, the carriers ask us for refunds or ask us to fund those deficits. We fund them out of this account. That does a couple of things for us. It helps us, first of all, gives us reserves to pay and collect, but it also stabilizes the premium rates or the county for the members. So it's very important that we keep this reserve. There's a board policy. This reserve is currently set at about 20% of the total plan premiums. And I know this number was thrown out yesterday. Annual plan premiums, about 925 million. You guys were calling it $1 billion, close enough. So this reserve is right at about that minimum balance. And we do get money into the account and we do pay deficits. I can't remember all of the number flows, but I remember paying about a $25 million deficit not that long ago to a carrier for a given year. Yes.
Yeah. The 5.8 billion is invested.
Yes.
Right?
Yes, it's invested in OPEB.
Okay. Where's the 199 million?
Yes, that's also invested.
Okay.
And
so everything in here is invested somehow.
There's some minor exceptions. The federal funds account is a interest-bearing bank account per the federal guidelines. It can't be at risk. That's 62.5 million. The checking account is literally an account where we pay. There's some overnight earnings from State Street on the checking account, but it would be minimal. Other than those two, the LACERA health account, that's the account we share with the treasurer tax collector. They invest that money overnight for us. So pretty much all of them are invested somehow.
Okay. Thanks.
Yeah, you're welcome. Let's see. Federal funds account, just briefly, that's the retiree drug subsidy and low income subsidy accounts. Those are federal programs. Cassandra submits claims. We get rebates. That money can be used to fund program benefits for the benefit of the members, for the benefit of the employer. Premiums account, a little bit of a high balance when I measured it at March 31 for this report. It's usually a little bit lower number, but this is where we pay all the premiums. Again, $925 million a year, 80 some million dollars a month. That's how we fund the carriers every month. The admin fee, that's the excess admin fees we've collected from the county that the county is currently drawing down to supplement that admin fee that I talked about a moment ago. Let's see, checking account, we have to pay bills for the retiree healthcare program. And finally, the one sort of oddball account is like I mentioned, we do share an account with the treasurer tax collector. When the county owes us money, they put money there. We take that money. When we owe the county money, like for example, for Cassandra's salaries for her team, we put money there. The county takes it to pay the payroll for LACERA. So let's see here. Okay, so very quickly on this, I'm going to start over on the right-hand side. This slide really just captures the responsibilities that me and my team fulfill, monitoring the accounts, the actual reporting, financial statements. We have 3 columns on our LACERA financial statements. We have the pension trust, we have the OPEB trust, and then we have the OPEB custodial fund. On that last slide, all of those accounts, except for the trust account, the 5.8, all the rest of the accounts encompass the custodial fund. So we report that. And again, that's essentially at the end of the day, that's money that LACERA is holding for the county to administer the program. So that's the custodial fund. And then on the left-hand side, fiduciary oversight. So this is really just capturing the essence of board reporting with our actual reports, the board approving those. The ACRE committee approves the SOC report. I'll talk a little bit about that in a minute. That's an internal controls report that's required by LACERA to perform. One thing I didn't include on this slide, we're talking about reporting responsibilities, sort of this oversight role. One unique thing that my team does with respect to OPEB is we formed a stakeholder group with the county and the county's consultants and actuaries. It's almost 50 people. And what we do there is every time there's a triennial cycle for the actual reporting, we actually go to the stakeholder group 3 times during the process. Again, LACERA is administering the program for the county, so we think it's important and critical to get the plan sponsors' input on the assumptions, to get their input on the preliminary results of the valuation. So we have an entrance conference. We say, okay, this is our triennial cycle. We're going to study the assumptions. The county has their actuary. There's a union actuary on the call. The county auditors are also on the call. The county's external auditors are also on the call. I'll talk a little bit about that in a minute. Because of all the reporting we do for the county's financial statements. So it's a collective group. So my point here is that when these materials come to your board, the actuarial reports, the experience studies, even the financial statements, the county's seen them, the county's looked at them, the county's provided us with their feedback. And so we find that that's a real collaborative partnership. There's no surprises. Everybody knows what's going on. We've even set up our timelines to manage around the county's financial statements. So we prepare all of our reports in time for the county to get their information for their financial reporting. So we think it's a pretty good process.
Mr. Granger,
yes.
A couple quick questions. The $8 fee that's charged to the that's charged to the retiree, correct? Or
yeah, it's part of each insurance plan. It is
right. Okay, so I retire. That's just it's whatever the cost of the plan. If your fringe is 10 grand, your plan costs 9,000. But there's an $8 fee on top of it, right?
Right. Once we get the final number from the carriers, that $8 is added on top of that.
So thank you.
So it's embedded in the premium.
Gotcha. Then my next question, they're using it to supplement the 13.8, right? Or what, roughly, or whatever it is.
Right.
That's going to draw down. And what's going to happen when that is there a chance for a large increase or spike of that fee? They're working and asking to supplement it with that money, right? Which was initially there because fees were that $8 negotiated fee built up this whole big savings account, right? And now, so what do you anticipate happening, and maybe how long it's going to happen until it gets drawn down?
Yeah.
Well, we've been in conversation with the county most recently about that. Their desire is to continue to draw down. One of the questions that they did inquire about was whether or not they could use some of the RDS money that we have to fund that at some point. So that's where our discussions are back and forth with them at this current time.
So the intention is to just try and maintain status quo with a low fee cost to the pensioner. But do you anticipate if that doesn't follow through? And so they have the same motivation, right? They're not looking at sticking it to folks. But is there a chance that might happen?
If I
Go ahead, Louis.
If I can jump in as well. Ted talked about Milliman's interaction and the actuarial reports that they're going to provide. One of the areas that we're having Milliman assist on and engage with the county is really forecasting that admin fee and looking at really more of a long-term solution on how, at different intervals, whether it's a 5, 10, 15, 20-year plan on how to pay that fee. So I think that's one of the areas of conversation we're having. So it's not just about the drawdown of that reserve account. It's really having a long-term plan on addressing this admin fee as opposed to this annual conversation and cycle that we have today.
Gotcha. Yeah. So it's like the Star Cola. Eventually it's going to be gone. Yeah.
Yeah.
So
That's what I meant about they would be able to look ahead and see that, oh, we see that an increase is coming up, or we may need to increase. So they'll know ahead of time, just as we do, as it continues to climb.
and just add for information, is this like the 1994 $8 fee? I mean, is it not relative to other systems? Like, would the actual fee cost for admin jump up to like 20 or $40 or something?
We've been very fortunate.
Yeah. Thank you.
Yeah. In terms of sort of the real time of the admin fee, we're currently calculating about $9.69. So we're not too far behind, but we are a little behind. So, but just to kind of regroup and summarize on the $8 fee. So we're currently at the $8. We are drawing down that $13 million excess. The county's looking at the RDS account that has about $65 million. In the meantime, we've engaged Milliman. We want them to fine tune it for us, and they have, and they've done a great job in helping us do that, get a better policy around that with the county. And then going forward, I'll add one more complexity to this whole thing, and that is the ADC, and I'll get to this in a minute, but that's the actuarial determined contribution. So the county is funding the program to the point where the actuary is saying, hey, you are fully contributing to the program with your two funding streams. And so what I'm thinking or hoping is that the county is going to start focusing a little bit less on all the elements of the program and more on the actual determined contribution, the one amount that the county owes. So I'm hoping that they'll start thinking and budgeting on the bigger number that's able to be projected by Milliman rather than all of these fine tunings. So if the admin fee does need to be increased, it won't be quite of a big concern to the county. So hope that made sense.
I know you told us before, Ted, but I forget that the OPEB, when we transition that kind of tipping point where we go into the sunset of not having to pay it forward, is there an anticipated timeline on it? It's considering everything the status quo right now, age, of retirees and all that actuarial stuff. Is there a point we can look forward to where the county it'll just be funded out of the OPEB?
Yeah, so maybe two answers to that question. One is in the next year or two, the county would be contributing the ADC, the actual determined contribution. They're contributing the full amount required to fund the plan. Funding levels, getting to maybe 100% funding, that's a ways out. Right, we're at about 19% funded status. So that's good. And we're getting a little bit ahead of the conversation, but that's why we need to go back to the county and talk a little bit more about a funding plan. What is the county's goal? So for example, let's say that we're looking at, 20, it's out there. I can't even remember the year right now. In terms of full funding, that target keeps moving a little bit because we have a 30-year amortization policy on our actuarial assumption. That's another thing we want to talk to the county about. So talking to the county about what is the funding plan, one of those actual assumptions would be addressing that 30-year amortization. That provides negative amortization. That's why we have 20-year on the pension side, but we still have 30-year on the OPEB side.
Yeah, I remember we talked about that in previous meetings, like not doing the full 30, but like looking at individual slides, like a decade, for example, or whatnot. Yeah.
Correct. So you're thinking exactly, you're actually a couple slides ahead, but that's why we do want to start talking to the county. I've had a very rough preliminary conversation with them about, hey, we do want to talk about an OPEB funding policy. And they've said, okay, we can talk. You know, we haven't gone much beyond that, but that'll be one of the things we address is what is the county's plan? What is a realistic plan? So I think the county getting to this ADC amount is sort of that precursor. It's sort of that point where the county can say, yay, we're fully contributing to the plan. What does the full funding of the plan look like? And what's the target there? Some plan sponsors think that 75% is their target, right? For pension, it's 100% for LACERA. The county might say it's 75, they might say it's 100. You know, how are we going to get there? Then the actuary can help us determine how to contribute those costs or how to satisfy those costs, depending on what that target is.
Yeah, that funding is based off if everybody retired at one time or everybody took, did the medical at one time, right? That's how they're determining it, which is not realistic, but yeah, so that's good. Thank you very much.
Okay, great. Thank you for the questions. Okay, I'll try to get through this slide quickly. I do like this slide because it talks to a lot of the work that my team performs. So you're familiar with the OPEB actuarial evaluation reports. Those are the annual reports provided to the board, funded status, ADC amounts, et cetera. The triennial experience study, that's coming up for 2026. We have Milliman starting to work on the 2026 triennial experience. We take a look at the assumptions. Remember the footnote there is that some of the pension assumptions carry over to OPEB, and then we look at the OPEB assumptions. I'll be interested to see if Milliman's medical trend assumption aligns with Siegel. In fact, I made a note to send Siegel slides to Milliman so Milliman can understand what's being communicated to the board and sort of sync those two up because Milliman does have medical trend assumption that we do take a look at on the OPEB evaluation. Audits of those. This is the year for 2026 where CABMAC will come in. We have a separate actuary that does the audits of both of those reports. They take a look at how the assumptions are developed. Is it within standards? Are the recommendations reasonable? Again, that benefits the board and the members by having that second look. And then they do an audit of the valuation report. Basically, they run a parallel valuation report and they compare the numbers side by side just to make sure they're reasonable. The next couple of three reports are essentially reports that we give to the county. And that's because LACERA administers this program on behalf of the county and the county prepares financial statements. The county has to rely on that information that we provide so they can prepare and so their auditors can audit their financial statements. So the first one is the GASB 75 report. That is the OPEB liability from the accountant's perspective. Remember back in 2017, 2018, the accountants decided that we're so smart that we can develop our own calculations for the liability outside of our normal actuarial funding calculations. So we have a net OPEB liability that the county puts on their financial statements. So readers of the county's financial statements can know how much the county is on the hook for in terms of providing LA County retirees with OPEB. So we have a GASB 75 report. We give that to the county. We have a specific report for the county for their slice of the OPEB trust. Schedule of fiduciary net position is a fancy way to say the county's holdings, their own holdings in the OPEB trust. And finally, controls. Because LACERA is gathering and providing all this information, the auditors have to come in and look at LACERA's controls, our internal controls over financial reporting. They have to audit us to make sure that that data output that we're giving to the county can be relied upon. In other words, if we have good controls, we're gathering good data and we're providing good data to the county. And then finally, last but not least, is our normal annual financial statements. Those are the October statements with the opinion. And then we have our fancy book in December with the org chart and the pictures and all of that. That's our ACFR annual comprehensive financial report. So Okay, a couple quick highlights on the calendar. I won't go through every month, but I did want to point out just a couple quick things. I think it shows from the calendar that we're working on reporting, RHC reporting for most of the year. Obviously, Cassandra works on it full time. January, February, that's the engagement that Cassandra alluded to. We're talking with the county about Cassandra's budget, and the county is not shy, and the county asks tough questions like, how many vacancies do you have still? Or what are your costs? Why are your costs going up over here or over there? We talk about the consulting fees that Milliman charges. So the county does do a deep dive. That's a process I'll talk a little bit more about in a minute, but we already have that regular cadence. We're trying to fine tune it. We're trying to enhance it. We're trying to formalize it better with the county. And again, they're not shy. So budget talks in January, February. March, Cassandra mentioned, that's the premium renewals. Those go to the board for the insurance, the upcoming fiscal year. We also have a SOC report and a GASB 75 report in April. Again, those are the reports we're getting to the county to get ready for their June reporting, financial statements. And new insurance renewals go into effect beginning fiscal year. And I think there's a session later that's going to talk about changing that. So I just wanted to point that out. Right now, it's a fiscal year renewal. And finally, I'll skip over to October through December. Those are the financial statements that I mentioned on the last slide. Okay, so we're getting close here. The top two lines, single stream funding and ADC, I've talked a little bit about that. I think Trustee Green was getting us ahead, but those two strategic initiatives kind of go hand in hand. As I mentioned, the county's getting close to fully contributing to the plan. They're hoping to reach that in the next year, year and a half. And when they do that, so let me back up. The county provides two sets of funding streams to LACERA currently. They provide the PAYGO costs on a monthly basis. That's the $925 million the county's funding. Literally, LACERA is a flow through. We take that money, we bill the county for all of the insurance premiums. Okay, let me back up. Cassandra develops an enrollment list. We bill the county gives us the money, we pay the carriers. That's the PAYGO costs. The pre-funding is at the county's discretion, about $575 million a year right now. They're giving us in pre-funding, that goes to John, that's for the OPEB trust. So total funding about $1.4 billion. The actuaries determined that that amount means they're fully contributing to OPEB, right, to the plan. So the county has said, hey, by the way, we're getting tired of the two funding streams, and it would be better for us if you give us one amount, the ADC amount, when we get there, and we'll provide you with one check, so to speak, or one transfer in this case. And it will help us with our budgeting. And by the way, Milliman can project the ADC because it's an actuarial number. That will include everything, the PAYGO costs, the $8 or $9, whatever that fee would be, the pre-funding costs. So those are two strategic initiatives we're excited about, we're getting closer to, and we're working in the background on achieving those. I'm sorry? Oh, I'm sorry, Ms. Langton.
No. Quick question, Ted. When they do send a lump sum, then will you be separating out still into OPEB? We'll just be doing the separation at our end?
Great question. So preliminarily, and we're actually not doing this in a vacuum. We have our investment team involved. We have our actuary involved. We're going to present something to the county when we get closer to what the plan looks like. Preliminarily, what our plan is, we're going to get the ADC amount. We're going to go ahead and take out, with Milliman's help in terms of the calculations and projections, we're going to take out the PAYGO costs, and sort of the leftover is going to be an OPEB trust contribution. Now, it gets a little tricky 15, 20 years from now, because in order to fund that PAYGO costs, we will have to draw down from the trust. The plan becomes mature, right? The county might have, I don't know, $20 billion in the fund, maybe more. And so that part gets a little tricky. Right now, we're focused on present day, and then we're going to start thinking about, what happens over time as it evolves. Make sense? Okay, cool. Great. Okay, a couple other quick things. And administrative fee review, Cassandra and I already alluded to that, fine-tuning that with the county, getting a more a solid sort of plan from the county. OPEB funding policy, I think we've already talked a little bit about that. We love to get conversations, more engagement from the county on that. What is their plan? What are the actuarial parameters we can build into that plan? And of course, always on our mind, always in our discussions with the county, the LMB. And so that just has to be there on the list. And I think we're getting close here. So just a quick, I'll just run through. Is that okay? Cassandra mentioned the 1982 agreement, right? The foundational legal document. We mentioned again the 6.1 billion combined in all the accounts. Predictable annual cadence. I want to just make sure it's clear that we already have an annual cadence with the county. Again, improving that cadence, fine tuning it, getting better, getting more information from the county, getting things solidified, getting an OPEB funding policy, those kinds of things. Working on the LMB. And then path to full funding, of course, all of the actuarial reports and analysis, whatever we can do to provide to help the county move forward with that plan. I think that's it. Sorry, did you have anything to add?
Was it?
Okay.
What about the other, I believe it's 5, other than the county and the Superior Court? What about our other 5 beneficiaries groups?
Yep, great. And so we have also participating in our OPEB program besides LACERA, the county, the court. We have AQMD. We have Local Agency Formation Commission of LA County, LA LAFCO, if you will. We have LACO, Los Angeles County Office of Education, and we have Little Lake Cemetery District. And I did pull a couple of statistics. Actually, Irvin pulled these for me. So currently, for example, LACO, there are no actives. They transitioned to another plan back in the 80s. So there's no more actives, but there are retirees from LACO. We have about 10 that utilize the OPEB program. For LAFCO, we have 6 actives. They're still in the LACERA pension system, and eventually they'll go into the OPEB program. Retiree side for LAFCO, they have about 9. Little Lake Cemetery, they have 1 active under LACERA, and they have 2 retirees that utilize OPEB. And then finally, AQMD, they transitioned to another plan years ago, but they do have 87 retirees that are in OPEB. So
And we're just waiting for them to phase out all of them? Or, I mean.
Yeah, so LAFCO and Little Lake have actives. We would anticipate that we'll continue to have actives and retirees, but the other 2, AQMD and LACO, yes, eventually those 2 plans will phase out.
And when you say active, does that mean active employee or active retiree?
Active employees.
Okay, so they haven't even gotten to us yet.
Correct.
Okay.
As far as OPEB, you're correct. Yes. Sure. Right. Yes. Yep. And okay, so any other questions, concerns, issues?
I have one question, if I may. I know it's right before lunch. I'm trying to be brief. I'm sure you're aware that there's some organizations that are the gap in PEPRA with dependent care for the retiree medical care, spouses and children. And so some organizations are doing working out a employee contributed fund, basically their own OPEB in a sense. Has that it's the one I know of is not, was discussed and agreed upon, ratified, years back, but now it's up and running. Has that been part of the conversation? Does that, it's totally separate because it's a self-funded thing, but I guess what I'm getting at is there, I think the way the county looked at it, they didn't want to be on the hook for it, but is there any discussion on that? I mean, I know you guys are aware.
I am aware that there are conversations going on. However, so far it's just been between the county and those individuals. Nothing has been talked about. I know what, for a minute, the county was talking about implementing a tier 3, but that got dropped. But other than just knowing conversations outside of LACERA is going on, we have not really been involved in it.
That really, the more, when I say it out loud, it doesn't really impact the retired medical care because it's off to the side for dependent care.
Right.
So, yeah, okay. Thank you.
Great.
Yep.
Great. Thank you.
Well, thank you for watching the clock, and it is time for us to start the afternoon session. So Cassandra, I'll let you take it away.
Thank you. So for this presentation, hope Steve and I don't put you to sleep, but following lunch, we'll be discussing the key operational, financial and member impact considerations associated with us transitioning, or the possibility of us being able to transition our retiree healthcare program from a fiscal year to a calendar year.
Thank you, Cassandra. So I think for context, I think LACERA has always done a good job of trying to integrate with kind of CMS or Medicare at various points in time. So again, the addition of the Medicare Advantage plans was a mutual opportunity that benefited the county as well as LACERA and the members. So I think what we're trying to do is kind of be aware of those things as they transpire and see what we can do. So what we're going to talk about is not new. So LACERA currently takes advantage of the retiree drug subsidy. It's something we report to the board on an annual basis. Cassandra and staff do a very thorough job of working in concert with the vendor partners, Anthem, CVS, Cigna, healthcare, et cetera, to draw that information and kind of pull that money together. We'll talk about kind of the value of that work a little bit later in the presentation. But we also need to recognize that the things are kind of changing. Constant change is constant, to be frank. So we're looking at, is this the best opportunity for us to proceed? Or should we be looking at something called an employer, oh my God.
Group waiver plan.
Thank you. I can only say the acronym, EGWIP. So as we kind of look at that, there are opportunities. It's, for context, both have been around, it's basically introduced at the same time. But as we went through the last session, LACERA's gone through kind of their renewal and budget cycle on a fiscal year basis to align with the county. So on that basis, that kind of made it worthwhile to stick with the RDS. What we're seeing though, as we move forward, is that the RDS is receiving less funding from CMS and more of that funding is being pushed towards the AGWIP programs. But in order to take advantage of the AGWIP program, we have to move to a calendar year basis. And I would say that was kind of a third rail for multiple years in terms of, is it worthwhile doing that? So I think we want to bring to your attention today is, if we were to go down this path, what obstacles do we see? What opportunities? What's the financial value on a prospective basis? And try to get a sense of where that's going to go. Again, the decision is kind of the board's, but for this presentation, we basically structured it as a kind of perspective of saying, if we did this, what are the steps that we would need to follow? How would that work? What are the potential opportunities, et cetera? So again, it's not intended to be a particular bias, but just a recognition of where the fund's coming from and what's perceived to be the best value for LACERA and its members. So what better way to use a SWOT analysis than to go through this process? So at the very high level for strengths, not surprisingly, I think we all watch TV from October through December and see all the CMS Medicare Advantage commercials just proliferate the airwaves. So it's like we're all aware of that. So that's something that happens. The next strength in terms of, again, if you were saying, let's make this transition, okay? What LACERA does not do, which we associate with most group employer health plans, is you don't have an open enrollment period. You know, active employees, you go through an open enrollment period kind of every spring. Coverage is effective July 1st, but there's kind of opportunities to make changes and decisions, et cetera. LACERA is a very different animal. There's no enrollment period, but members can transition between plans, but the requisite is they need to give at least 6 months notice. So it's a very different dynamic. So you don't see kind of mass migrations. And that's actually one of the kind of pillars of the negotiations with regard to extending or increasing the lifetime maximum benefit. Because one of the concerns on the county side was, well, what if everybody moves all at once because of open enrollment? It's like, we don't have one. So it's like, understand the program we have and let's apply some rationale to it. So from a strength perspective, that can be considered a strength. I think which was covered really well in the last session. Weaknesses is kind of determining the calendar year transition sequence. You know, very simply put, here's 7/1 renewal date. If we want to get to a calendar year basis, we need to find a bridge of 6 months. We either do it at the front end or the back end. And so we'll kind of talk about how that could work. I love the word stakeholder because there are many. You've got the county, which manages on a fiscal year basis and will continue to do so. We're only examining this because of the potential opportunity to, access more CMS funds for the overall program. Stakeholder education also involves members. It's like, even if we make this change, and as I pointed out a moment ago, there's no open enrollment. There's nothing required of the retirees as we make this transition. but just the idea or the announcement of we're transitioning from July to January 1st. It's like, I'm sure everybody would go, okay, what's going on? What's the impact to me? And it's like, there potentially could be some, but it's not going to be like a massive disruption in order to do that. The other is managing calendar year and policy renewals within the same fiscal year. You know, to be honest, like we pointed out a moment ago, the county is never going to change from a fiscal year. That's fine. But what they end up doing is having to manage basically 2 health renewal cycles over one fiscal period. So it's kind of like half of one versus half of the other, and it's always a transition. So we'll kind of touch on that one. Opportunity side, we're looking at enhanced federal subsidies, which could improve kind of the fiscal efficiency of the retiree healthcare program. And then perceived threats, which is, again, not taking advantage of funds that are available. So can we take advantage of that and kind of apply it to the program and again, extend kind of the value and benefits into the future? And secondly, from a threat perspective on a member basis, you know, tier 2 retirees are essentially granted coverage for themselves, but they're responsible for the payments for dependents. So if the cost of premiums continue to rise and we don't take advantage of other resources, that ultimately is going to impact the retirees. So those are at a very high level, and we'll get into a little bit more detail as we go through this process, but that's kind of the basic discussion outline for whether or not to transition to a calendar year plan. So any questions so far? Yes.
Sorry, give me 1 second. When you say there's no open enrollment, does that mean you get in a plan and you just stay in a plan and it automatically renews? Or do you mean no new people coming in?
It would be, if I sign up for Kaiser as an example, I can go into that and I'm going to just automatically renew kind of into the future. It's really the only transition might occur if I was a pre-Medicare retiree. And then at some point I become Medicare eligible, then they would transfer to Kaiser's Senior Advantage plan, which is the Medicare Advantage option. So that would be something, but once they're kind of in a plan, I'd say 90% or more of LACERA members, once they've elected a plan, basically ride that out throughout kind of the rest of their coverage period.
Thank you.
To expand upon that, sometimes, as you know, we have members that decide to move out of California, that may move somewhere where there is no Kaiser or no United Health. Those are what we call exceptions. And so rather than members like as an active employee, we have to wait until October to sign up for January. Our retirees can make a change anytime during a year. However, there is a 6-month waiting period before that actual change takes effect.
But they're still covered for that 6
They're
months.
still
with
covered
the
during,
old-
correct.
Yep, got
They're
it.
still covered during they're in their current plan.
But if they move or they go someplace where the plan they're in now is no longer available, that 6-month
That is an
waived, right?
exception. That is
Yeah.
what we call an exception. So
Right.
in that case, they would be able to change right away.
That's actually a great scenario of why that lifetime maximum benefit provision is so important to us, because as members choose to relocate outside of California or outside of kind of the service areas, they have very few options available through LACERA. So again, everything's intertwined. I'm going to use the spaghetti analogy once again. We didn't have it for lunch, but we're having it for the presentation. Right, so why don't we kind of delve into the strengths just a little bit more? So again, kind of at a high level, aligning with a calendar year basis really syncs us up with the CMS calendar.
Yeah.
So as you can see, we've got 5 different scenarios, and Sandra, do you want to kind of walk through those?
Sure. So our initial enrollment period is when you have 3 months before or 3 months after your 65th birthday to enroll in Medicare. So that's what we consider the initial enrollment period. As Steve just mentioned not long ago, there is an annual enrollment period. This is when members are getting a plethora of mailings. You walk in the grocery store, you see them with booths out there to get them signed up. That's what this annual enrollment period is, from October through December. In January, for those, say I was 65 and I decided not to take my Medicare when I first turned 65. January through March 31st would be the time that I would say, hey, you know what? I should have taken it. That's the time that I would use to go and sign up for my Part B. Given though, because I had decided not to take it initially, I then will be penalized. So it depends on the number of years that I elected not to take it and I decide to go back, how much that penalty will be. There's also a general enrollment period that goes on between January and March. And those, they can make changes in plans and all of that stuff during that period. The special enrollment period, the last number 5, are people that say, I'm still working at age 65. Because I'm still working, I don't have to take Medicare. I just need to let Social Security know, hey, I'm still working. As long as I can show creditable coverage at the time that I do decide to retire, and it's within these months here, last 8 months for up to 8 months, I can then sign up under this special enrollment period, letting them know, hey, I've decided to retire. I'm retiring on this date. I'm coming to get my Part B Medicare now. And I provide them the verification that I did have creditable coverage. There's no penalty there.
I can only imagine LACERA member, I have LACERA's programs, right? I'm signed up and I'm just tracking along. And then suddenly, because the calendar changes a month, suddenly everyone's inundated with stuff. You know, it's like, for many, that's like, it's just, it should be trash because there's no reason for them to do anything. But again, kind of aligning with this cycle might actually help LACERA staff and others to kind of even better educate members what you do or don't need to do and try to avoid some of that confusion.
So as a reminder, under the LACERA Retiree Healthcare Program, again, there is no annual open enrollment period. Members must enroll within 60 days from their retirement date or the board agenda date, the board letter date. If they go beyond that 6 month or that 60-day period, then that's when that 6-month waiting period comes in. That's what we consider the late enrollment because they've gone beyond the 60-day period. And it would be 6 months from the time that LACERA receives their signed application requesting and notifying us that they're of their intent or desire to be enrolled in a LACERA plan. For members that say they get married after retirement or have a baby, the request is that they provide notification to LACERA, providing marriage certificate, birth certificate within 30 days of that qualifying event, and we would then place that dependent on that member's account.
So we're going to bridge now to kind of perceived weaknesses. So first and foremost is kind of how do you transition from a plan year that's on a fiscal basis to a calendar year basis? So the easiest answer of all is like, it's 18 months. Let's just do an 18-month contract. So straight, simple. I know what the rate is, it'll be constant, and we'll go forward. In reality, it's not that simple. And let's focus on the Medicare Advantage eligible participants, just to kind of put that in context. So as we talked about, CMS runs on a calendar year basis. Everything gets factored, calculated, and kind of people submit bids and people get reimbursements and they kind of know what my rate's going to be. And we'll talk about kind of when that cycle happens a little bit later in the presentation, but it's basically everything from a Medicare Advantage perspective is geared towards January to December. And CMS funding and kind of residual financial resources that are part of that kind of get lost as we work on renewals for LACERA today on a 7/1 to 6/30. We're not taking advantage of some of the financial benefits that are embedded into kind of the overall programs. So in essence, we could have a lower rate if we're calendared to, January to December, but we're not. So we kind of get a little bit less than we think. So the idea is those vendors, getting back to my original point, don't want to look too far into the future and say, okay, I'll give you 18 months because they don't know what that last 6 months is going to be. So in essence, it's like, how do we transition to a calendar basis? So it's basically one of two options. We go in 6 months, 6-month contract, and then a 12-month contract. It's the shortest period of time to bridge us to what we think will be the opportunity, but it creates some issues. How do we educate members? How do we ensure that people understand what the transition is and is not, so that we don't create kind of confusion or panic, but just kind of working through that process. So it's kind of tough to do. The alternative is like, let's take some time. Let's really educate people on how we're going to do this. Let's do a 12-month cycle. So we're going to do our normal stretch, which would be from January to June. And then on the back end, you do that 6 months. In essence, what you're doing is potentially foregoing some potential savings for at least 18 months. So again, we'll talk about what that might be worth financially. But at some point, it's like you're going to have to rip the Band-Aid off at some point. So it's either you do it on the front end or the back end. But it's like, that's kind of the options that really exist, because trying to get multiple vendor partners to give us an 18-month contract when that is not the norm for them and would be outside their cycle is going to be a challenge. So stakeholder education, again, I think we kind of broached that pretty well during the last session. but the county works on a fiscal basis. The whole accounting cycle and everything that was mapped out in that last presentation was very kind of detailed and, it has a set pattern. I think nobody appreciates that more than we do as we work through the renewal process, understanding what are we trying to get to and how are we trying to get it done so that by the time we get to January, as Cassandra said, we finalize the renewals. We know what it is now. We've gone through basically 4 to 5 months of negotiations to get to that point. And then we're bringing it to the committee, then we bring it to the board, and then it processes through. And then we're working on the communications work, which is, eating up a lot of staff's time at this point. So it's like, that's pretty rote. I don't see the line of sight to the county, but I can certainly see how it's challenging, which is we're used to you being on the same cycle as us. Now, from an accounting or fiscal standpoint, you're trying to kind of interrupt our process and jump in and jump out. Could be a perception. So it's like, but it can be done. We talked about members too. I think the idea of trying not to kind of position members to see this as an impact to them. It's like we're trying to get to a point we think where there are financial benefits to them, but there should not be the disruption. But it will still be challenging because any change, someone's going to have some thought or is there a conspiracy? How is this happening? Why is this happening? Probably the most practical one would be as we transition and the rates for 6 months to 12 or even 12 to 6, doesn't matter. A carrier's rates come in higher than the benchmark plan. We have a couple that kind of fit that mode today. So in the end, someone might be in a position where it's like their cost could increase in that next transition. So whether it's 6 to 12 months, it's like, okay, my rates went up and usually it's 12 months. This time it's 6, but it should be an anomaly. But again, we want people to be prepared for that. And I think as a contingency, one of the thoughts was, is that a waiver opportunity to kind of say, usually it's 6 months, but because of this change and transition, do we consider that as maybe an option to say, okay, we'll kind of waive that 6-month waiting period for that scenario. So it could be a one-time spot. That's Trustee.
Thanks. I'm sorry. I should have raised this a minute ago, but earlier in your discussion, but it took, I'm not a numbers person, so it took a little bit of time. You were talking about the impact on a reason why the insurers or the carriers might be unwilling to extend a contract for an 18-month period because of not being able to predict costs, et cetera. To some extent, aren't they doing that already? I mean, when their rates are from January through December, we hop in July on whatever the rate exists then, but they're committed through the following June, which is the first 6 months of the subsequent fiscal year. So they're already having to anticipate when they set those rates to contract with us effective July 1st, they are guessing, if you will, or estimating what their reimbursement and costs are going to be for the first 6 months of the next calendar year, aren't they?
Yeah.
So is this really a different time period, but is it realistically any different in terms of their anxiety level?
Can't speak for their anxiety level, but
Well, but you were talking about that they might be reluctant to do it, and that made sense. But as I started thinking about it, shouldn't they have the same degree of reluctance in the current circumstance?
yeah, I would say if I were to take the perspective of like just a commercial account, take retirees out of the mix, take Medicare out of the mix. I've been at this over 35 years. The idea of going, can we get a 18-month? Can I get a 24-month contract? To your point, we're just projecting the same amount. We're just trying to get some stability in the overall rate, et cetera. So it's like, could I go out that far? And it's like, we do it for long-term disability. We do it for life insurance. 5-year, 7-year rate guarantees exist. But when you get to healthcare, it's just been entrenched in a kind of 12-month cycle. So it's like, that's what they're accustomed to. That's what they do. But the rub is going to be for our retiree population, the element that's missing. It's not just the idea of projecting the cost, but now they go to the next source of revenue, which comes from CMS and going, what are you going to be paying us next year? Because that is a blind spot for them. So
That's my point. CMS starts paying them a new rate effective January of any year, but they're contracting with us effective July under the existing rate. But then when they calculate that rate, it has to be based on their best estimate of what they'll be collecting from January through June. So they're doing that right now because we aren't in sync with with the CMS rate period.
Yeah.
So I'm missing where the concern
I
is.
acknowledge it's tough. I think to take LACERA out of the mix from a calendar standpoint, when they're rating out the Medicare Advantage plans, Kaiser, United Healthcare, Anthem, doesn't matter who, they don't really have line of sight to what CMS is going to be reimbursing until April. And they're developing those rates, and those rates are being developed for, let's say, January of 2027. So they're getting that insight or that input. The difficult part for LACERA is like we're in July, so they're getting that input, but they're getting it for kind of the future. So we're kind of really looking backwards. So we're just kind of missing the timing.
I got you. Okay, thank you.
But very good question, because it's, again, I could spin myself into a hole going 6 months, 12 months, 12 months, 6 months, 18 months. Like, I just want to get to the point where it's like we're normal, like everybody else, but that transition is going to have some level of uncertainty until we kind of effectively make that. But then we're on the same path as everybody else. So, but I appreciate the question. Number 3, managing calendar year versus fiscal year budgets. You are where you are, but there are others that have kind of gone before you and actually do manage this. Again, I'm no accountant, but it's like there are processes in place where they figure out how to balance that between, half of one policy period plus half the other in that fiscal budget that they're managing. So it's like some is what I know and some is what's projected, and you kind of combine them into something. But in terms of kind of peers, both cities and counties of San Diego and San Francisco are able to do this, and there's certainly others, but I just want to use those as some tangible peers as a benchmark to saying it can be done. But it's, again, I think efforts like, Tech Ranger and others kind of working with county staff to, how do we bridge this? How do we kind of navigate that process together, not only the first time, but probably over a couple cycles to get it to the point where it is today, where it's very standard and rote.
So as you know, we currently participate in the retiree drug subsidy program. That program's been in effect since January of 2006. As a result of the Medicare Modernization Act. We are eligible under the retiree drug subsidy program of 28% of the aggregate amount between the cost threshold and the cost limit. There's no calendar year.
Is the table too high?
Yeah. There's no calendar year requirement such as there is in the EGWIP program. So that's kind of a little difference in between, although both programs did start in 2006. The mere fact that we were on a fiscal year versus a calendar year, it was never thought that we would be able to switch over to a calendar year. However, now given that we're seeing that there's less funding that's available through the retiree drug subsidy program, and with the cost of healthcare going up and all, we thought it was time for an opportune time to have that discussion with the county to see if it was even possible for us to make that change. In talking with the county's budget people, they did indicate that there may be opportunity, hence we're exploring it in a deeper, with a deeper eye to see if this is something that we can definitely do.
So on this chart is a kind of historic look back on the RDS reimbursements that LACERA has received. And, again, I think taking advantage of anything that's available through kind of CMS with federal government to kind of fund this retiree program is important. We got a lot of stuff there because we are showing numbers from Anthem Blue Cross, Cigna, Kaiser, and Local 1014. If you could kind of hone in on the green bar, which would be the aggregate, give you some sense of kind of where things are at. So going back to 2019, 2020, the amount was 12.1 million, increased to 12.4, increased to 12.6. It's a nice trajectory. And then it came kind of crashing back in 22, 23 to about 9.4 million. And it kind of up just a little bit to almost 9.9 million in the most recent year. The other thing to keep in mind too, though, is that this is all retrospective. So everything's already happened. And then we're going back and filing for these reimbursements. So again, a lot of kind of staff time, et cetera, to kind of make this possible. But we're also recognizing the funds that are available through here are going to be declining, or anticipate they would be declining in time. So it's kind of like, again, we're just trying to look at this and saying, what's this opportunity worth to LACERA and its members? And what's the value to the county?
Steve?
Yes.
If you can just elaborate just for context for the board, obviously we know that Anthem and Kaiser have most of our retiree population, but there's a huge discrepancy on reimbursement. So can you just elaborate why Kaiser's much lower and Anthem has a lot higher reimbursement rate for RDS?
Yeah, so the Kaiser program's kind of, well, it's a great question. Anthem's about 50% of your group and Kaiser's about 50% of your group, so it just kind of balances out to that. That's why the focus is there. Forgive me, I'm probably a little bit lost. I didn't get dessert today.
What I'm thinking, and maybe this is an assumption, but with Kaiser being an HMO and Anthem being, we have CVS Caremark. So I think that's kind of the big discrepancy is that the PPO side.
Jogging anything in my head that would work. So Kaiser is, as we all know, is kind of an integrated healthcare system. So they're doing everything kind of internally. So from budgeting to service of care, one of those elements of care management is related to the pharmaceutical management process. They are very aggressive in terms of how they manage overall drug spend, et cetera. Their generic rate, I think, as Daljeet pointed out earlier today, is it probably approaches close to 85-90% generic substitution when possible. So they do that very aggressively and very well. All their physicians are tied into that too. So when they're looking at members' diagnosis, the prescriptive therapies that are available and kind of what they're going to use, it's all kind of there and managed and kind of, done in integrated fashion. With respect to Anthem as an example, it's an indemnity plan. Members are free to choose who they see. Those providers are free to kind of dispense kind of what they want. And then we work in partnership with CVS to kind of manage that process to ensure the drugs are being delivered appropriately, as cost effectively as possible, et cetera. So there are some discrepancies in kind of the pharmacy spend. We expect Kaiser's to be slightly less than Anthem's. So as we look at that chart and going, why is one larger than the other? It's just a different philosophy of managing healthcare and how they approach that. So that address your question? Great. Thank you.
Because Kaiser's a managed program, they're able to keep a more effective lid on the costs.
They do manage their programs a little bit more effectively or aggressively than kind of other plans, which are kind of fee for service. So that's just kind of the nature of the game.
Some people would say that they're being denied care that way, or I mean, what's the flip side of the coin there? The good news is they run more efficiently. The bad news is what? Is there any bad news, or is that a matter of opinion?
I chalk it up to a matter of opinion. I think there are distinct individuals are kind of distinct in terms of how they want to access care. There are those that want to be kind of in charge and lead it. And I would say for the retiree healthcare programs, kind of the Anthem plans kind of fit that mold. I want to be in charge of what I do, see the physicians I want to see, seek out the treatments that I feel would be in my best, my best service. For Kaiser members, and I would say, again, not specific to LACERA, but just across the board, I'd say Kaiser works out very well for members that may approach healthcare a little more passively. They're kind of willing, they want to work within that system. The system will direct them to where they go. And it just kind of, that's kind of how that process works. There can be times where, to your point, I may have a condition or something where it's like, okay, there are options that I know exist outside for treatment. But Kaiser might be a little bit more conservative in that approach in terms of how they stair-step access to those treatments, or when they draw in resources that might actually be outside their system. They will still contract with others to ensure access to that care, but that process might be a little bit slower, a little bit more methodical than going to a specialist, arranging for a surgery and having it done like that. You may go through a little bit more checks and balances within the Kaiser system to get the same level of treatment for the same issue.
And often what I hear from members is having Kaiser is like a one-stop shop. I have my lab there, I have my doctor visit there, my pharmacy all in one area. Whereas those that are in Anthem Blue Cross, they want to go to their doctor. They don't mind driving off to some other facility to get their lab work done. So I hear that often from members that they like having everything in one place. But again, it goes to individuals' choices.
Yeah, I'm not being judgmental. I was just kind of thinking out loud. I mean, as a retiree dealing with retirees, I don't hear a lot of complaints from the Kaiser people.
They've been in there 40 years.
They're pretty happy campers. And for the most part, I I hear as many complaints from the people in Anthem because many times they have to wait longer to see a specialist, or they have to wait longer to get something done. That's changed a little bit lately because I think Kaiser's a little stressed right now with staffing and stuff. But I know with somebody who's in a fee-for-service plan, it ain't always easy to go and see a specialist.
Thank you for the questions. So we'll transition. So the employer group waiver program, kind of what is it? As Cassandra mentioned, it's been in existence since 2006, so it's not new. It is kind of perspective. So it is integrated into the overall group health plan. So members still receive care through the Anthem plan, as an example, and the drug plan will kind of process through this. But the plan, the EGWIP program will be administered as an example through CVS or perhaps another vendor partner. But how that works, but what we're getting access to is some of those residual subsidies that kind of go missing when we're kind of outside relying only on RDS. So they're direct subsidies, reinsurance, low income subsidies, et cetera. So as all these things kind of come together, it does create a potential for some additional kind of financial value. So on the next chart is just a quick summary between the two. So as we pointed out, the RDS, it doesn't have a plan year requirement. The EGWIP again must be on a calendar year basis. Federal funding, so RDS again is limited to that corridor that Cassandra mentioned, kind of the floor and the ceiling, up to not about 20% of that subsidy. So that's about what's available. As noted just a moment ago, for EGWIP, there are multiple Part D subsidies that kind of combine to hopefully kind of soup up the value of what's available. Rebates. You get rebates currently through your relationships with CVS and Anthem, so that still exists. The EGWIP also offers access to those. I will caveat that with all the transparency talk and kind of where we're going. I don't know how much longer that element will have legs. There's still other things going on with EGWIP that are, beneficial, but rebates is going to be a question. Where are we going to evolve over the next 3 to 5 years? How is that going to change? I can't tell you right now. But looking at all things kind of all in at this point, the savings level through RDS is, I'll round up. Let's say we're looking at about $10 million per year at this moment in time. And that could decline over future years. The EGWIP is projected to be anywhere between 2 and 4 times the RDS value. So we could be at 20, we could be at $40 million on an annual basis. So it's again, not something that I think can be easily ignored. Again, it's entirely up to the board to determine, is this worth it or not? But there's that value there. Subsidy timing, I referenced it briefly, but it's on the RDS, it's retrospective. So again, everything's happened and then you're filing to get reimbursed. So everything happens in reverse. For the EGWIP, it's more perspective and ongoing. So in essence, we kind of know what the drug costs are going to be, what the subsidies are going to be. And so it's like, it will have a kind of dampening effect on the overall rate. So it'll keep it down in terms of having it just kind of rise. So we'll have a better idea of going, what are the rates? Right now we get RDS reimbursements, which is great, but it goes into the reserve, which is used for a variety of appropriate purposes, but it doesn't directly impact the rate because we've done that rate 2 or 3 years ago. We're doing EGWIP, it's kind of more in real time. So we're kind of basically working through the renewal process and understanding what that rate's going to be. And we're going to be benefiting from that EGWIP subsidy as those prices are being developed. So that frankly could help, again, using as an example, a tier 2 retiree who has to cover dependents. Knowing what the real number is and kind of paying that as opposed to paying perhaps an inflated number. And then unless they're getting an RDS reimbursement, not quite as efficient and not as directly beneficial to the member. So there's some potential there. Administration for the RDS, I've typed in high, maybe Cassandra can tell, maybe give you guys a better example of how much effort is actually goes into that RDS work.
I would have to give that credit to Leilani for LACERA. There's quite a bit of work. We have to go through filing an application annually and then filing the cost, working with the carriers to file the cost and, the numbers, making sure that, we have the correct individuals included in those files when we send them over to CMS. There's regular mailings that need to be going out to those individuals. So it's quite a bit of work on behalf of LACERA staff. By changing over to the EGWIP program, there's not that much. It's more from the plan, the plan's benefit of having to do a lot of that administrative work as opposed to the LACERA staff doing what we have to do.
I will second, Leilani has done a fantastic job for multiple years trying to, you know, if you want to, you can give her credit for 10 or $12 million. I think she's worth it. So. But we go to kind of the next point. So we've kind of talked about, again, where we think there's potential opportunity that's worth exploring and how do we do that? How does that work? Now we're going to kind of try and make it a little bit more tangible. So LACERA is unique. You've had your vendor partners for decades. Okay? It is very relationship oriented. It's very difficult to just kind of say, oh, we just market this or we'll do an RFP for this, because everything you do is so integrated and there are requirements. Again, managing your plan designs from 1982. There are not many vendor partners that could step up and going, oh, I can do that, because they haven't had a claim system that would pay that for the last 15 years. So I don't know how they would process the claims anyway. So it's like partnership is critical. So what we did is we did this initial assessment. We decided to take a look at opportunities through either Anthem or CVS. And what we wanted to do, a lot of plan sponsors do this on a self-funded basis, and that is fairly routine. Large states, large counties all do AGWEBs that are generally self-funded. But we also recognize that LACERA and the county have relied on fully insured contracts for a very long time, and it's for appropriate reasons, which is like, you know, stability. I know what it is. I can budget it. It's going to be what it is. So there are no unusual spikes month to month, year to year. So we're going through the premiums and then we adjust on a renewal cycle to kind of figure that out. So self-funding is certainly an option through AGWIP, but we'd also ask for fully insured alternatives as well. Now, again, from a timing perspective, what we'll share with you is what we found out is that, you know, neither Anthem nor CVS would be willing to kind of put a fully insured proposal on the table until we got into the third quarter. And that's not just for this year, that would be every year. So whether we choose to do this in 27 or 28, you have to realize it's like you might have a self-funded proposal, but if your preference is to be fully insured, then there's some additional wait time to kind of get on that cycle and make that happen. So it's just something I want you to be aware of.
And that's just a change from when we first started talking about the employer group waiver plan. Back when we first started thinking about it, Kathy Magida and I were entertaining speaking with our carrier, our vendor partners. And at the time, fully insured opportunities were not even a thought or an offer. So it's changing as time goes. So I'm happy to hear that they are at least looking and considering the fully insured. So stay tuned, because I'm not sure about the county wanting to go self-funded.
And I think we're trying to be kind of respectful of everybody's positions and preferences. So it's like, as we navigate this, it's not a slam dunk, but there are, I think, good opportunities going forward. From a financial perspective, I think we can tell you the self-funded proposal received from Anthem and CVS kind of fit that model of anywhere between 2 and 4 times the RDS value. So again, that could be, again, 20 to 40 million, you know, all things being equal. So it's like, okay, that's a positive. Would the fully insured proposal meet that same threshold? It might be a little bit less because they're taking on risk. It's, you know, understood, and we certainly respect that. But this gives you some sense of, okay, is there a financial opportunity here? We think so. Question is, how's the best way to address that, and how's the best way to navigate administrative burdens that go with it? Beyond the financial impact, there's non-financial criteria, and, you know, quite simply put, we'd want to look at what's the retail pharmacy access, right? So an AGWIP may have access to every pharmacy on every corner. That's great. Others may be a little bit more restrictive. They may be more reliant on, we talked about earlier today, kind of narrow networks. So if you only go to my pharmacies, wherever I'd presume to be, then the price point is lower than if I let you go anywhere else. So again, those are all different option and decision points that we'd need to make, but that's an important criteria as we're talking about what's the potential impact to participants. You know, if I do a full broad network, the savings are less, but the disruption is minimal and it's kind of fairly smooth. If we're really aggressive for savings, but there's disruption, there'll be time and expense to be paid for that, just trying to respond to that process. Other things to consider.
Steve, with respect to the non-financial criteria, the good or bad? You didn't really give any I'm just sitting here thinking about this whole, so is this a good thing? Or is this a bad thing? Or is this something that isn't gonna make a whole lot of difference?
I think the non-financial do make a difference. So I'd say, again, on his premise, I would say the options we looked at, kind of just use it as a beta test. We think the financial value is there and it's worth investigating. The non-financial criteria would need to be evaluated on a cursory basis. I'd say there's some advantages for one vendor over another, but in different areas. So it's not absolute, and I'm recognizing I have Anthem in here today, and I'm not going to get into any more detail on that, but I'd say it would and should be a competitive process. So the idea is that we're not done other than this test told us there's a financial opportunity and there are criteria that we would take into account to help LACERA navigate kind of that final piece. All right. Savings are savings, which is great, but at what cost? What impact on members? So again, we're really looking at this from a balanced perspective. So, any questions on that? All right. So we spent a lot of time talking about kind of the AWIC program and kind of financial advantages of getting to a calendar year basis. We broached on this earlier in the conversation, but you have 55% of your membership are in a Medicare Advantage plan, pretty close to the national average. The bulk of those are actually concentrated with Kaiser Permanente. Again, in California, that is the norm. So there's nothing unusual about that. But what we're missing out on with whether it's Kaiser, United Healthcare, et cetera, SCAN, is that CMS again works their calendar. And by April, they're telling you for the following year, this is what we're going to contribute. You can bid on kind of the contracts and we'll kind of figure it out and we'll finish it up by, July. Okay, that's great. But for us, because we're currently on a July to June, we don't get the advantage of no one's taking a bet on LACERA for that second half of the year going, well, we're getting this much from CMS. Maybe we'll get the same amount next year. Nobody is taking a risk with what's coming out of the federal government. It's like, I want to know what I'm getting first, which is why it's so hard for us to kind of figure out 12 and 6 or 6 and 12. It's kind of like, I have to navigate to that point, but it's still going to be a bit of a transition. But we also know, because we've asked the vendor partners through the renewal process, and we've done that, as Cassandra pointed out, we go through a process kind of, I won't call it back room, but kind of working diligently from the fall through kind of the end of the beginning of the new year, kind of really working it. But we have a day that we spend with your vendor partners, meeting with them, they're meeting with staff, and we're doing this in real time and having discussions. And oftentimes we'll go, okay, what's the potential impact if we were a calendar year plan? Oh, well, the Medicare Advantage rates would be less because we know we're getting from CMS and we could do all that. And it's like, well, if you already know, why can't you do it? It's like, because you don't get that money. We won't get that money for LACERA. So it's like, we know there's some additional residual benefit beyond the egg whip that could provide some additional efficiencies financially to benefit, again, LACERA and its members. So it's like, there's some positive here to what we're looking at. And it's not just all on egg whip. So I think we're kind of excited about that process and kind of iterated it earlier, but from a rate development cycle, again, it's very simplistic. In April, CMS will announce their base capitation rates. In June, organizations submit their bids to get responses and kind of what they're going to be. And then after that, the monthly capitation amounts are kind of dispersed. So April and June are prospective, and number 3 is kind of ongoing. That happens every year, all year. But it's basically who's enrolled, what are we going to give as a head count? If the membership changes, it gets additions, they'll add money to it. If a member's risk should kind of skew negatively, then there are additional funds that are available to help kind of manage that care. So all those revenue streams going to the Medicare Advantage plans are important, but we also want to make sure that we're able to take advantage of that. So that's the reason why it's like, from a residual standpoint, egg whip, potentially Medicare Advantage plans is kind of the additional element to it. So I think there's a couple threads here that can be beneficial if in the end, the board decides this makes sense. We'll give this one to you.
So by participating in the egg whip program, you see there are some potential savings and things that we could do that would be beneficial to the county. However, if we were to, you might want to take the first part, surrender the CMS subsidies and maintain our fiscal year, we're definitely losing out on some money. we already know because of the timing that the carriers find out that how much they will be getting. So we've already lost out a potential on that, which increases our premiums. Because had we known what that amount was, the premium could have been less, thereby saving the plan sponsor as well as the members that pay a portion of their premium, as well as those with their dependents. I mean, even though for the tier 2 people, the county doesn't pay for dependents, the member is paying. So the member is paying more. For the tier 1 people, the county will cover dependents and therefore the plan sponsor is paying more money. Yeah, so that basically covers both of those on there, tied in there. You know, members aren't eligible for the full subsidy. They're paying a higher premium.
Again, to me, it's nothing we've brought up this afternoon is new. Okay? Cassandra, Kathy McGee have kind of looked at this, discussed it, kind of probably agonized over it at some point. When is this worthwhile again? Could you move to a calendar year basis? Well, maybe the county wasn't prepared or couldn't do that. Understood. Okay, the county wants to be fully insured. Okay, all bets are off. We can't accomplish that based on where the market's at. So as things have evolved, are we at a different point, an inflection point that says, okay, maybe things are beginning to align that we could take advantage of it. And again, it could be win-win, but it's not without effort. So again, if everything went perfectly and we went, yes, let's do this. Yes, let's do 6 month to 12 month. Okay, great. And then when let's work prospectively, let's get this done. We still know that members will still be going, what's going on? Why is everything changing? You know, what's the value or what's the benefit to us in trying to figure that out? How to help the county stakeholders kind of pivot and going, I had a system. I know that's not easy for someone to going, we've been doing it forever like this. It's great. Can we keep it up? And it's like, I just have to ask, is doing more of the same if you had access to $20 to $40 million a year? Is there value to a little bit of pain to do that? And again, potentially yes, but again, I'll leave that up to the board to decide.
Yeah. I have heard from a couple of people asking, oh, have you guys heard of the employer group waiver plan? Yes, we have. Or are you guys even considering it? We've looked into it. So now with the changes coming up and we're seeing down the road that the retiree drug subsidy program may not weigh out where we could be getting as much federal funding on behalf of the county. We're really looking into it and was happy to hear that the county would look into and say that this is something that we may be able to do. So stay tuned. We'll be back with more information as it become available. As Steve said, it's still a moving part, but we just wanted to make sure that we gave you early info on it. And should you have any other questions, we will stand for those questions. None. Going once, going twice.
Thanks for your time. I think I'll just broach it. We have the panel on GLP-1s is next. We have 3 physicians actually joining us from CVS, Anthem, and Kaiser. CVS physicians here, thank you for being here. I think Dr. Karam just came in. I see a hand wave. Dr. Petrick? Yeah, she was actually, I think, doing rounds. She's actually an engaged physician. So I think we need to take a little break until she can join us and we'll go from there.
And if I'm not mistaken, she's coming from Woodland Hills, so. So let's finish off our day. For our last presentation, we have a panel which will be moderated by Steve Murphy from Siegel. Our panel is comprised of representatives from Anthem, CVS Health, as well as Kaiser. We have Dr. Carol, who is lead medical director for Anthem's Grievance and Appeals Department out of their Woodland Hills office. He's responsible for managing daily operations of the medical team, appeals team, and also interfacing with the California regulators on medical issues. He received his medical degree from Jefferson College of Medicine and his MBA from Fox School of Business at Temple University. We also have Dr. So Ree, who's currently serves as medical director of medical affairs and at CVS, providing clinical expertise across the utilization management, research initiatives, and clinical program development. And lastly, but certainly not least, we have the beautiful Dr. Kimberly Petrick, who is a Kaiser Permanente provider. She joined Kaiser in 2015 as a family medicine physician practicing out of their Woodland Hills Medical Center. She serves as ambassador and as physician lead for the Southern California Permanente Medical Group. Thank you, panel, and Steve, there you go.
Well, you talk all day, you don't get an introduction. Rightfully so. Who else wants to be done with me? I do. So this presentation, I think its genesis is actually a number of months ago, but I think just based on the questions from today, it's like there's a lot of interest. We either personally or we know someone who's kind of exploring or using GLP-1, so there's kind of strong opinions either way. So I think what we're going to do is structure this in a couple ways. Number one, Dr. Ree will provide kind of an overview, a good foundation for us for GLP-1s. We've kind of touched on it all day long, but I think her material is going to help kind of give a center or foundation. And then we'll transition to Dr. Petrick, who will talk about kind of the Kaiser model and kind of how GLP-1s are used and how they benefit patients. And then we'll transition lastly to kind of Anthem, which kind of, what do they call it, bury the lead. So Kaiser Permanente works through the Department of Managed Healthcare. Just one agency, pretty straightforward. Anthem has to straddle two. Department of Managed Healthcare, as well as the Department of Insurance. And those rules are different. And because we have multiple plans under different categories, that influences kind of how members access GLP-1s, et cetera. So we're just kind of foundational, Kaiser specifically, and then we'll kind of delve into Anthem, and then we'll kind of take your questions as we go. So without further ado, I'm going to get good at what I've been doing all week.
My pleasure to meet you all. My name is Dr. Sue Ree. And I'll be presenting largely a clinical overview of GLP-1 medications. Next slide, please. So it all started with a venomous lizard. Don't know if all of you are familiar with the GLP-1 story. So I thought I would have more of that type of approach because there's so much focus on different aspects, but it really did start with a clinical interest. There in the 1980s, there was a biochemist, Jean-Pierre Rochard, and he was interested in what venom from different types of animals could possibly have an impact on human physiology. His work was picked up by, got the interest of an endocrinologist named Dr. John Eng, who was at the VA in New York at the time. And he saw, wow, they isolated a peptide from the venom of the Gila monster and noticed that it reduced sugars in diabetic mice. He had strong interest in the 1990s, but could not get support from his hospital, from different pharmaceutical agencies. And then in 1993, he mortgaged his home to file his own patent. But it took another 3 years for any pharmaceutical industry to take interest. So at the ADA conference in 1996, Amylin was a pharmaceutical company at the time, took note of a poster. A guy from Lilly also walked by, looked at the same poster. And long story short, there was a collaboration in 2002 that then led to the first FDA approval of the first GLP-1 medication, which was exenatide. That story was really the birth or origin of GLP-1 medication. And the interest here I forgot to note the reason that Jean-Pierre Richard was interested in the Gila monster venom is that the Gila monster only eats 3 to 4 times a year, sometimes only twice a year. So there was some consideration as to how is that possible and what is going on. But anyhow, so then that leads us to the first FDA approval for a GLP-1 medication. And this was novel because this was the first non-insulin injectable. And it was the first medication that could really target the pathophysiology or the disease process behind diabetes outside of insulin and outside of pills that only got so far. And then that led to about almost a decade. So about from 2005 until about 2015, there were only GLP-1s for diabetes, except for Saxenda, which was an injectable form of same version of Victoza, which was a GLP-1 for diabetes. But really, you didn't have much weight loss. And in diabetes, in general, to this day, even with the newer agents, you don't have as much weight loss as in people who don't have diabetes. So the effect is not associated with weight in diabetes. There are other mechanisms. And so therefore, really this interest started with this concept of could we make headway in this very difficult disease process of type 2 diabetes. And then there was note when Ozempic came out. So Ozempic came out in 2017 for diabetes. And there was still in the diabetic population, there was a significant more weight loss than all the other agents previously. So this is now like 12 years in. And so then that's what started this next craze with the FDA approval of Wegovy. So when you hear people talk about GLP-1, there's GLP-1, there's combo agent, GLP / what they call GIP. GLP and GIP are what they call incretin molecules. If you never hear it elsewhere, at least you heard it once, because then there are 2 other types of molecules that are coming out that come from the pancreas called glucagon, and then there's another one called amylin. But long story short, this was the origin of the story, the past. The next slide, please. So then you're thinking, wow, how did we get from that to where we are today? So GLP-1, although really it was studied on its effect on the glucose metabolism, really what we found is that it works throughout the body. There's receptors throughout the body, and you're really looking at the heart, the brain, the stomach, the liver, the pancreas, the muscle, the gut, the fat, possibly the joints. So this ubiquitous effect across the board. And what really is the difference with these second generation molecules are how impactful they are. Okay, next slide, please. So this is one of those very boring slides, but I thought it was probably the best way to illustrate, and it's small, but hopefully you can see on the screens in front of you. Really you have, and one agent's not on here, but it's in shortage now called Trulicity. But really you see what started with diabetes. Now you see several agents that are approved also for obesity. Oftentimes it's the same generic name. Semaglutide is Ozempic and Wegovy. Tirzepatide is Mounjaro and Zepbound. And then, you know, what you've seen in the last 3 years, 9 FDA indications, just in the last, it's the last 2 because Zepbound came out at the end of 23. But really what you're seeing is not just diabetes and obesity, but now MASH, which is metabolic dysfunction associated steatohepatitis. It's a mouthful, but basically it's fibrotic liver in people who have liver disease not due to alcohol. So non-alcoholic fatty liver is really the old terminology. Obstructive sleep apnea, cardiovascular risk reduction, and chronic kidney disease. The chronic kidney disease is something that isn't mentioned very much, but if you have type 2 diabetes, this is another indication. Okay, next slide, please. So what's on the horizon? So we started with diabetes. we have metabolic disease, and we have things kind of associated with metabolic disease. But what we're seeing is further foray in metabolic disease, including type 1. So it used to be thought that GLP-1s wouldn't work in type 1 because they don't have much insulin production. But it's proving actually there are mechanisms. GLP-1 has mechanisms outside of even just insulin production, and therefore it is effective. So that's coming. Plaque psoriasis and psoriatic arthritis. This is going to be really big because this is the departure from metabolic disease. And the first study that was published was end of March, so really recent. And at 4 weeks, they showed a separation of effectiveness when people used a combo GLP-1 called Zepbound, as well as a biologic. And that was called the Together PSA study. And that at 4 weeks, that was before weight loss. And so you're really seeing benefit. And then you're going to see Crohn's, IBD, heart failure, osteoarthritis, and some others down the line. The next slide. So this one and the next one can be quick. You can just see later at your leisure, kind of the pipeline, the anticipated pipeline of approvals that will be coming in these different indications. And so you're really moving beyond weight loss and beyond diabetes into other disease processes. The reason I like this one is because it just gives you a visual of a timeline, but you can see at your leisure later. That's why I mentioned the different types of molecules. You have incretins, you have pancreatic hormones, because what you see with these blue letters are not only new indications, new medications, but also different combinations. So you have a single agent, GLP-1, you have a dual agent on the market now with tirzepatide, which is Mounjaro and Zepbound, and then you're coming with triple agents coming. And then you'll have combinations, other combinations. Okay, next slide. So, it's still the question that often surrounds these is the cost management approach, and I think my colleagues will also approach that. But just simply put, high-level overview, CVS Caremark looks at coverage, control, and personalized support. And I think that's it.
Thank you very much for the foundation. Always feels good when a panel who's never been together before keeps nodding their heads in unison going, huh? All right, we're off to a good start. We bridge to Kaiser, so Dr. Patrick.
Great job. Hello, everybody. Thank you for inviting Kaiser Permanente to the table here. It's a very relevant discussion and very excited to be here. I was just mentioning that we've already had with one of our groups earlier today, a very heated conversation around GLP-1s. So I know it's still a very hot topic. So let's jump into that. Go ahead to the next slide. So within Kaiser Permanente, if any of you are familiar with the way that care is delivered within KP, it's an integrated structure. That also means that every point of prescription has pure intention. And if we went for everybody who wanted a GLP-1 medication just because they wanted it, and this was the question that was happening as well for people who were on it for novel sake, purchasing it online through different vendors, then really the healthcare system would be bankrupt. It is a very expensive medication, and it's not medically or clinically appropriate for everyone. So we want to make sure that when we are prescribing it, we're not doing it in an isolated fashion. I think one of the shortages that exists in healthcare today is that there's not enough support that comes around an individual that wants a medication, but that needs monitoring and needs additional support that makes sure that we're doing it in a safe and strategic fashion. So if I started singing to you guys, which cover your ears because it's not cute, but if I started saying, oh, everybody knows what the jingle is because they've created millions of dollars in advertisement to ensure that we have recognition around semaglutide brands like Wegovy or like Ozempic. And it's because of that that there is such high demand. But with that said, if we are going to prescribe it, we need to make sure that we're doing it with lifestyle modifications, because we know that over 85% of people will not be able to sustain GLP-1 medications for more than 2 years. The problem is, we also know that from what we know so far, rather, is that this is likely a lifelong investment in health. So what we also know is that if we have not created sustainable change, lifestyle modifications that truly make sure that every facet of that person's life is now headed in a direction of healthier being, then frequently people will not only regain their weight, but gain even more. We know that the quick, instant gratification that people have with this is weight loss, yes, but it's also about 60% lean muscle mass. So if we're not helping invest in dietary changes, exercise changes, and really a collaborative, integrated approach to how we prescribe this medication, it will not have the same long-term effect that our society truly needs. And again, it's an astronomical cost. So what we do is we want to make sure that we are prescribing it strategically. For us, if it's a diabetic individual, we will often start with other medications and see if a GLP-1 medication is necessary. What we do see is that in our system, still about 75% of patients that are prescribed GLP-1 medications are diabetic individuals. For you guys, we're seeing over 60% prescribing for diabetic individuals. But it's really about making sure that we are doing this in a personalized and strategic way. If we can do the same effective weight loss, so if we're going to focus more on the weight loss rather than diabetes, if we're going to focus on this weight loss journey and we want a partnership with these individuals, we want to make sure that we're doing it with less expensive medications that have proven long-term effectiveness. And there are a lot of oral medications that do exist in the system. So again, it's really about making sure that we are doing something that is clinically and medically necessary rather than what is the hot topic or the spicy commercial that everybody is really trying to chase after, because there is no such thing as a silver bullet in weight loss. Go ahead to the next slide for me. So again, there's not one reason why obesity exists. Just as there is not one reason or one way to be able to treat that obesity and help it go away for life. This is really the fundamental of us as human beings. There are so many factors that come into play in my clinic every single day, but also what has taken an individual to where they are today. And weight loss is not just, here's a prescription and please go ahead and lose the weight and we'll see you again next year. Really, it's about making sure that when we're looking at an individual, we're looking at that individual. That when we're looking at their weight, it's not in silo. It's not just about weight. It's about who their family is, what their cultural beliefs are, what is their support system at home. Because guys, if we're going home and we're giving them a GLP-1 and they're going to go have fried chicken for dinner every single night, we're not helping create sustainable change. But as we saw a few slides ago, if we haven't created a foundational differentiation in lifestyle modifications, we're going to see the weight come back plus more. So it's really about working with the whole individual, focusing on who they are, what their social drivers of health are, what their comorbidities or other chronic conditions are. How can we help support them, not just in individual, but community, healthier dietary practices, affordable eating, helping get the family gym memberships, or something that can create a long-term sustainable change. Are there a lot of new medications on the horizon, as Dr. Ree was mentioning? Yes, absolutely. But does that mean that they will be the long-term solution to weight? Fundamentally, I think the true answer is if we don't, as a society or as clinicians, focus on an individual's health from the base up, all we're doing is trying to fix the top floor without understanding that the base and that foundation might be cracked. And so we need to make sure we're helping the whole individual and looking at them and making sure we're complementing their life and not just creating a temporary solution. And we want to do this in a safe but also cost-effective manner. We know, as we had seen in slide 1, that GLP-1 medications, the cost is still upwards of $12,000 to $16,000 a year. And with the number of individuals that are being prescribed this medication, it's astronomical, right? And it's astronomically expensive. So we want to make sure that when we are prescribing this medication, we're doing so in a very concerted effort to sustain and save costs. So within Kaiser Permanente, what we will frequently do is we monitor for side effects. We start with the lowest dose. We do a 30-day prescription, and we don't provide longer-term prescriptions until we see that there is sustainable effectiveness. So we do 30-day prescriptions. We do monthly check-ins with these individuals. We ensure that at these monthly check-ins, we have wellness coaching that is aligned with them, or the health education department, or that they have some degree of support to help make sure that if there is an obstacle or if there is something that is occurring with interfering with their wellness and betterment strategy, we can help them tackle that so that it's not just a medication, but it's a global understanding of holistic self-care. The other thing is that at the end of 16 weeks, we set that as a real, true set point, where at 16 weeks, we check in with the patient through their weight loss journey. And we do ask that while we're titrating their medication, they come in monthly for a weight check to make sure that we're showing progress, because if they're not showing progress, then it might not be the right medicine for them. But at the end of 16 weeks, if we haven't seen at least a 5% total body weight loss, then it might not be the right medication, and talking about other alternate therapies may be a better option. So we truly want to make sure that we are treating the whole individual, but keeping it with a cost-effective medication and making sure that we're having effective solutions for the reason that they've come to us in the first place. Okay. Go ahead. And, you know, it's truly making sure that we are creating a pharmaceutical understanding of lower cost. We want to competitively purchase. We are a large purchasing organization. We do not usually refer outside of KP, but because of this, we're able to purchase medications in bulk, which really does help allow us to keep and sustain lower costs for you guys and for all of our employer groups. Go ahead to the next slide for me.
Can I ask you a couple questions?
Would love it if you would, my friend.
I want to back up to page 19. Your chart where it says 85% of patients stop taking GLP-1s within 2 years.
Yes.
My question is, why?
So there's different factors. What we do know, and the physician up here could probably support this as well, is majority of patients, well, there's a few factors that play in. Number one is the cost, right? So I think we do need to acknowledge the elephant in the room that the cost of this is often very high. And so for some individuals, especially if they're paying out of pocket for the medication, it's just not a sustainable
Well, I
cost.
figured that was the number one reason, cost.
Yeah, so that's absolutely a contributor. But the side effects are also still very real. Okay. We have a lot of patients that have intractable nausea, vomiting, just don't feel their best self. So they might feel like they're looking really great, but if they are not complementing their lifestyle by feeling really well as well, then it's not the right medication for them. So it's multifactorial with that 85%.
That fits the bill of a friend of mine who stopped taking it for that reason. My second question has to do with the 66% number. Mm-hmm. A weight loss comes back within a year. Yep. Once again, why is that?
Yeah, so that comes back to that foundation, right? If we keep putting stucco on the wall of the building that keeps getting a crack in it, but we haven't looked at what's underlying that foundation or that building itself, and it could be something in the foundation. It's the same concept with GLP-1s and obesity. If we're not addressing the lifestyle, the investment into the self-care, whether it's diet, exercise, social normities, community interactions, social support, then the habit that frequently may have led somebody to unhealthy habits that could have contributed to obesity won't be addressed. So for us, it's making sure that if we do have to discontinue the GLP-1 medication, we've helped them create better eating habits, better lifestyle and exercise habits, and things that will support long-term success, because we truly don't know how long somebody has to be on this medication to change that set point in their body that will help keep a sustainable weight loss without needing medication. But as far as we know, it's a lifelong investment, at least so far.
May I ask a couple questions since we've taken a break? Right here.
Oh, yes.
Thanks.
Sorry, thank you.
The first part of this presentation, I interpreted, and maybe I misinterpreted, more as addressing the use of these medications in treating various health conditions.
Mhm.
Your focus seems to be exclusively on using it to treat obesity.
Mhm.
Does Kaiser prescribe this medication for its members for obesity?
Yes, thank you for clarifying that. So there's different categories, and we'll actually look at your utilization in just a, oh, so let's jump there too. So we can see the breakdown where it's for diabetes, is also for obesity with a BMI above 40, but then there's also obesity with a BMI above 30 with secondary conditions like obstructive sleep apnea that Dr. Ree was mentioning, and all other members may be something like a BMI above 27, but with a history of heart attack, stroke, peripheral artery disease. So all of those are still completely covered.
Okay.
But the largest demand that we've been seeing is for obesity, and oftentimes it comes with obesity with other conditions and not exclusive to diabetes. But this is actually, thank you for the segue, because it's a perfect segue into LACERA's utilization around GLP-1s.
Okay, can I stop you before you
Please.
segue? Okay, I'm gonna take a little pause. With respect to the Anthem plans, are these medications covered under our Anthem plans for conditions, for obesity only, and not for whether you don't have an underlying health condition?
Steve, maybe it would be a good chance to go to that slide that covers the upcoming Anthem coverage.
If I'm throwing off your cadence, we can wait, but.
It was just 2 slides ahead there. So yes, so for the Anthem plans, the pharmacy benefits are covered through CVS, and CVS is actually in the process of doing an operational update to add the GLP-1 coverage. It should be going into place by July, actually, so coming up here just in a short while. And it will cover all indications, so weight loss, as well as the other indications that CVS Dr. Ree had just covered. And it will, the coverage will be based on the indication. So if it's for weight loss, depending on which plan you're on, it will have a certain criteria, and we'll cover that in the upcoming slides.
Okay, so we'll have greater compatibility then between our 2 main plans.
That's correct.
Yes.
Okay, great. Thank you.
Can I ask a question? Hi. So you hear a lot more in the news about nutrient insufficiency or malnutrition with GLP-1s. Do you see that a lot in your practice? And also, how do you monitor for that, or how often do you monitor?
Is that directed to me? Okay, I'll take the lead on that. I can't say that I see a lot of nutritional deficiencies as much as it's, again, just making sure, and possibly it's the way that KP addresses it with making sure that we connect them with wellness coaches or health education departments, nutritional coaching from day one to ensure that we are creating a sustainable change that's healthy, which I know, and this is not for sake of Anthem, but I know that it doesn't exist with all prescribing bodies for GLP-1 medications or even the combination medications that we see. So for us, I don't see it in clinical practice. I've not had much of anybody come in with concerns of that in clinic, but it may also be the approach for which we make sure that we're keeping a close, tight watch with them. Thank you for the question.
But just a moment, just to kind of piggyback on that. I think we need to be aware that these are powerful medications. These are medications, like I shared, that were initially, like the person who even brought it to the market or to healthcare was really looking at it from, how does this work in your body? How does this help your disease processes? But as was shared, when somebody doesn't have support, the appropriate level of support and or care management around that, that's when the weight loss can be too rapid, or they don't know that they need to support themselves with dietary changes like increased protein, things like that. They might just be happy that the weight is falling off without being aware that that there could be potential deficiency. So I think that's just a theme, is understanding that this is not a fad, that these are medications with a purpose.
Yeah, it'd be nice to see the breakdown, see if it's people getting it from the compounding websites that don't have the support. And I knew a couple of people and she's like, all I want to eat is crab meat. That's all I eat. I was like, you're headed toward malnutrition right there. You don't have any support at all. Sorry, thanks.
Yeah, and sorry to interrupt. Yeah, go ahead. Yeah. What about going back to the 66%, 85% page, please. What about the other 34%? What happens to their weight loss when they come off of the medication? Do they gain it back in 5 years? Do some of them not gain it back at all? Do you have a breakdown for that?
I don't, and I think it's purely speculative. I think to reflect on anything other than the numbers that I've shown in research, my guess is, and if any of my colleagues have any additional information, I think ultimately the hope is that other 35% or 34% has created a sustainable change model for their lifestyle to be able to create a difference, which I have seen in some patients that have come off the medication and have sustained weight loss. So there is proven benefit, and not everybody has to stay on it long term. But for those who have not created sustainable changes, then we see the frequent rebound in weight.
Yeah, just to comment there, in the clinical studies, the weight regain was very rapid. Like definitely within the first year, if not the first several, like for 6 months or so. I think what was mentioned is obesity. If you're looking only at obesity, not at all the other conditions, but just obesity. It is true. It's a multifactorial, both from within the body and then even outside the body. So the social determinants of health is also a large component. Weight maintenance, weight loss maintenance in general has been a holy grail. That is just, and I think that speaks to the fact that it is a multifactorial process. So I think that if you compare not just GLP-1 and not, but any intervention, and then who's able to sustain, then it starts to kind of clarify the picture more. But this speaks to the other question about why does the weight come back? When somebody is on a GLP-1 for any reason, diabetes or not, there is a biochemical difference in the body. And then I know that was like a very simple slide about brain, gut, all over the place, that there are GLP-1 receptors within the kidney as well, within the liver. So biochemically, when that medication is gone, it's not simply appetite suppression. There is just the person, I've been on a biologic for my own condition. When somebody's on a pharmaceutical, and then when somebody is not on a pharmaceutical, it does change the nature of what's going on. So that's a simplistic way of looking at above and beyond just appetite suppression. Why does the weight come back?
And just to clarify, I think I should have asked what happens to the other 15%, because part of that 66% is within that 85%. I assume that's a 2-year weight gain. Oh, they stopped taking. Never mind. It was the 66%. Okay. Sorry.
Just, if I may, one question. Does the body ever build up a tolerance?
I would say it's a good question because there are certain receptors in the body that will develop a tolerance, like the opioid receptors, the mu receptor. And so for that, they will develop a tolerance, almost like a resistance. So you need more and more and more. And this is a different type of receptor in the body that you don't see necessarily that type of situation. But what you do see is you do see a dose-dependent impact. So that's when you see in diabetes, you'll see in A1C, oh, how effective is Mounjaro? Or how effective is Ozempic? At the highest doses, you can get the highest level of A1C reduction, but then you hit a plateau. That plateau is not like a tolerance level, but it's a limit of the capacity of that mechanism in the body.
Okay, thank you.
Mm-hmm.
Where do I go from here? Up and back and up and back.
Thank you guys for all the engaging questions.
Patrick, I think you had this one. Did you have anything else on the?
No, so this is just a reflection to again show you guys LACERA's population, both with the early retirees as well as the Medicare retirees. And how that breaks down. We can see your total membership in the farthest column to the right. And then below that in the light blue highlight, we can see the number of total members that are being treated. But I want to bring your attention to really the diabetes column, as we showed earlier, that about 75% of our population, GLP-1 medications are still being utilized to treat diabetes. So in your population, we're seeing the Medicare population is about 62%, or it's 62 and 68% comparatively. So we're still seeing that a large majority of the GLP-1 medications that are being prescribed in your population are for diabetes. But we can also see the breakdown then of those individuals who are being prescribed it for other medical conditions. And these are all members that are covered under the health plan.
When you look at a Medicare population, how do you balance loss of weight with loss of muscle mass?
So that's really the relationship with the primary care and the doctor to make sure that we're having those touch points to ensure that we're doing it in a safe manner, and that the person is still thriving, whether it's monitoring blood sugar levels if they're diabetics, monitoring different lab levels, monitoring their weight with regards to exercise, their dietary habits, and really making sure we have those monthly check-ins, especially as we're titrating the medication. And then after that, what I'll frequently do is say, okay, you're really doing well. You're stable on this current dose. We have the 16-week check-in. And once they're doing okay, I'll say, let's schedule a telephone visit or a video visit in another 3 months and check back in and see how you're doing. But it's that constant partnership in health to ensure that we're both in the game together and that this is not a journey that they're taking by themselves. Thank you, guys.
Thank you very much. All right, we are going to transition to the Anthem component. And I wanted to really spend some time on this slide based on yesterday's presentations, because we realized there are two different entities that manage healthcare policies within the state of California: Department of Insurance, Department of Managed Healthcare. So anyone that was here yesterday realizes that the California Department of Insurance was established in the thousands, that's what we were told. But, again, basically auto, health, homeowners, it's the crab bucket of everything, right? In 2000, Department of Managed Healthcare was introduced because we basically had branched out. Managed healthcare, integrated system models, et cetera, became the primary delivery of healthcare in California. And so people wanted more regulations or oversight to ensure that members had access when care was reasonable and appropriate, et cetera. So we have these two columns, but they are not regulated the same. When the Department of Managed Healthcare was introduced, they did not integrate them. They just kind of kept them separate. And so we kind of have these two different spheres. So as we mentioned at the kickoff, Kaiser is under the Department of Managed Healthcare. So it's very simple. Manage through those regulations, we go straight forward. Anthem has got more complications to it. A lot of it depends on where the contract kind of is sited, or more importantly, kind of where those members reside. Are they in California or are they outside of California? So I'm going to kind of transition here to the Anthem team, and they've got I think a real nice summary of kind of what it looks like, but it's pretty straightforward. Is that if you're in California, we have one set of rules. If you're outside of California, slightly different set. But again, still trying to provide access appropriate to the medical standards. So Dr. Karen?
All right, well, I am Joe Karam. Have not said much, but I did stay at a Holiday Inn last night. So, basically, your Anthem plans have two, as Steve said, two different managers. Knox Keene is the governing statute for healthcare in California. With anything, and it's true of Medicare, the law is written, and then the CMS and here Department of Managed Healthcare (CDI) then interpret the law and tell us how it's going to be, how they're going to enforce it. Their job is enforcing law. They also have the job of interpreting it. When it came to weight loss drugs, there was a little bit of a diversion. California Department of Insurance. So the law requires coverage for weight loss drugs for morbid obesity. So no health plan can deny it for morbid obesity. The term morbid obesity is not used anymore. It's class 1, class 2, class 3. So the best approximation is class 3, which is considered a BMI of 40 or greater. So we cover, the DMHC plans cover weight loss drugs if your BMI is 40 or greater. Other than that, then there's no coverage, and that's how they get reviewed. The CDI said, no, we don't agree with the law, and they have this latitude, and they've insisted that since it's a drug, it be reviewed like any other drug. So we then use our criteria, which are basically the FDA recommendations for weight loss. So basically a BMI of 27 or greater with a comorbid condition, and a BMI of 30 or greater, period. That's the broadest overview. It's a little bit more complicated than that. But then the next question is, what's a comorbid condition? And, from looking at these cases every day, I will tell you that everything is a comorbid condition. So that's a little bit more difficult to define. And when it comes to, so then the FDA then had other indications, allowed for other indications for these drugs. For instance, Wegovy, I'll use the example of cardiovascular risk reduction. Well, who doesn't want to have their cardiovascular risk reduced? So we get all of these requests, from a 30-year-old who's got a grandfather who had a stroke at age 80. Doesn't qualify as cardiovascular risk reduction. In point of fact, the FDA approved this, and you know better than I do, so correct me if I'm wrong, Dr. E, but the study that got the FDA approval actually only looked at people who had already had a previous MI or had a previous stroke for cardiovascular risk reduction. And guidelines are then developed based on the study. So, I do have members coming and saying, you mean I have to have a heart attack before I can get this drug to reduce my risk? And, the answer is yes, because that's what was studied. Unfortunately, what may seem common sense to us as lay people may not be that way when you look at the studies. So how was the study structured, and what was the approval based on? So these are the things we struggle with every day. So, and I know you probably have friends or maybe some of you have tried to get approval for the weight loss drugs. As Dr. Patrick said, this is not cheap. Although I've been at Anthem long enough to remember 10 years ago when I thought $16,000 a year for a drug would be a lot of money. Now, when I see the pipeline every week, if it's under $1 million, I'm happy. Per person, per drug. And just anecdotally, a friend of mine worked for Pfizer, and they came up with the genetic cure for sickle cell anemia. They based their price on what it costs to treat somebody with sickle cell anemia for their entire lifetime. So they priced it at $4 million because the average cost is $4.2 million, I think he said. So that's how this happens. It's not punitive, but there are certain facts that are, may not be evident or obvious out there. And the other thing, as long as I'm speaking, I want to throw in, but I don't want to interrupt the cadence. When we talk about reasons and things about, what long-term complications are, please remember that these are relatively new drugs, even though they came out a long time ago, relatively new in use. they have enough data for approval by the FDA for certain indications. But in this day and age, it's not unusual to see a drug reduced in what their indication is, or even taken off the market. We don't see it as much anymore, but I'm old enough to remember some drugs that were the best thing since sliced bread that 10 years later we found out might be causing serious damage and get removed. These are new drugs. We basically only have 3 years worth of people using them. The problem is, just like you guys said, weight loss is a hot topic. The fact that we are sitting here now at the end of your conference, spending an hour talking about GLP-1s, just goes to show you what the interest is. Our appeals volume has increased 30 to 40%, and it's all GLP-1s. I can't tell you. I will tell you that a good 50% of my day is looking at GLP-1 drugs. And that's in addition to the other things that I do. So there will be other studies. The other thing is the cost. I had a conversation with our plan president, and I told her my opinion was that eventually the cost of these drugs will come down. Well, they haven't, and they're not. I think weight loss is a different topic. So I've learned. I can shoot my mouth off as well as the next guy. But weight loss is such a hot topic. Weight Watchers has been around. I mean, obviously they had bankruptcy, but we're always looking for a new, better way to lose weight. So they're not going to go away. The drugs that you're looking at today, Wegovy, Zepbound in particular, those two will be long by the wayside in another 2 years because we have other drugs coming in. And those drugs are going to be more expensive. So even if the price of Zepbound and Wegovy drop, nobody's going to be interested in prescribing them anyway because the newer, better drug is coming along.
I have a question. Is it cheaper to get this medication in Canada? I mean, that's just what I hear. I don't know. I'm asking you.
I think the consensus is we don't know. Yeah. Hypothetically, I would have patients in clinic who would get their medications from Canada, from Mexico, because, or other countries. Other countries, you don't necessarily even need a prescription, or healthcare is done differently.
Thank you. My coworker just reminded me I could have asked Chat. So
I can just tell you that my husband needed injections in his knees, and the doctor told him, here's the pharmacy in Canada that you need to go to because the shots are $800 there and they're like $6,000 or something if you get them here. So I don't know about this stuff, but I have personal experience with the whatever that Synvisc, or I think it's called, for his knees. So
They were cheaper. I don't know if they still are, but that's why Canada actually cut off Americans from getting them there because they were getting shortages there. We had shortages here and people were going there. And so Canada was like, stop. But yeah, I don't know about now, but I'd imagine lower. Yeah.
I will also add, we see, since you guys are talking about affordability, I do see a lot of patients that go online to compounding pharmacies, and I really do encourage people to do that with significant caution because safety and cleanliness of these medications and manufacturing is not known. Same thing with medications outside of our country. We don't have regulation around it, so we cannot guarantee how good that medication is or what it's being compounded with, if there's any kind of fungal components or there are a lot of contaminants that can occur, and the medication is not always done safely. So that's why we always encourage people to stay stateside.
Yeah, I'll just piggyback off of that because it was a good question and good commentary. I think toward the question of safety, long-term safety or short-term safety, there really hasn't been this type of direct-to-consumer access for a pharmaceutical agent of this nature. I think that's a nuance or a novelty, and things that cannot be tracked because it's either cash pay or something to that nature. But when somebody shows up, say in an ER or ends up having a complication and they say I was on a GLP-1, it becomes difficult to then parse out the story behind a clinical indication like MASH. MASH is a disease altering indication. You have people, cirrhosis, I trained at a liver transplant center. Cirrhosis is a devastating illness. And I think to have an agent that could reverse fibrosis before you get there, that is not talked about like it is in weight. And so therefore that's just a word of caution to consider, parsing out the noise and or the very valid cost considerations and all these things and safety with the confounding factors of something like a Super Bowl ad and access. You don't really need to even go out of the country. You can get it here, but safety, the safe administration and care management around it. The way that my colleague here shared that it's being done, that is actually by guideline, to have a monthly check-in, guideline by the Obesity Society, to have a monthly check-in until you're done, until you're safe, until, how do you prevent muscle mass loss? Well, you just, you make sure the rate of weight loss is not too high. So there is a lot of confounding storylines that make it difficult to parse out the true stories. So therefore, I appreciate that you're having 3 physicians talk about it from our different perspectives.
I will say that we do require that you have an in-person visit and actual weight measured. I still look at cases every day, and I can't tell you how many we get from weight loss apps on the phone. Patients never been seen. They're being treated by a doctor across the country. And you basically sign on, say, I would like Wegovy, Zepbound, fill in the blank. And they say, do you have a history of thyroid cancer in your family? And they say no, even though people may not even know. And the prescription gets sent. There's no weight, there's no height, there's no BMI measured, nothing. We do see this even with non-app based, where people call up and it says, it has to say telehealth video, telehealth visit, telephone visit, and there's no follow-up. And I think that's really, really important. If the drugs are going to be effective, there needs to be objective evidence, counseling. We learned that with bariatric surgery. That was going to be the best thing in the world. And I'm a surgeon. And, we thought we were going to cure the world of obesity by doing gastric bypasses. And amazing how many people don't actually lose weight. How do you not lose weight when your stomach is a third or a quarter the size of what it used to be? Well, it's because you're eating the wrong things. So if, you get a gastric bypass operation, but you're eating nothing but chocolate, those are high dense caloric, intake, and you're not going to lose weight. Same thing will happen with the GLP-1s.
Just to follow up on that, I was sharing with my colleague here a few minutes ago, a woman that I worked with many years ago who worked for me, was pretty overweight. Her family had a history of serious diabetes. Her dad had a part of his leg amputated. He was in a wheelchair, and she was maybe 35 and just got spooked and went to Cedars to consult with a bariatric surgeon. And this probably, it was in the 2000s. I would say it's maybe 20 years ago. The doctor would not perform the surgery on her until she completed 6 months of counseling, mental health counseling, got involved in a physical activity program, attended regular sessions with a dietitian, etc. She had the surgery, and she is still as trim as she was the day, once she recovered. Yeah, but it was strictly due to, and she would be the first to say it was due to the social changes. I mean, she'd grown up in a family that didn't value those things and had to really learn good health habits in order to maintain that and maintain her health. And she's now much older, but very healthy very healthy woman. So I can see the value in it in this same setting here.
I just say, I'll hold myself to 30 seconds. I really hesitate to tell this story, but last night I'm skimming through the television, come across this story of them checking for things going through TSA. And here's a customs agent talking to some guy, and he thinks he might be from Russia, Eastern Europe somewhere. What do you got in your suitcase? Oh, just some drugs for personal use. Gee, you have a key to the suitcase? No, well, no problem. I got the universal one. He snaps it off. This entire suitcase is full of these drugs. And he's just going through them one at a time. What do you got this for? Oh, it's all for personal use. And it was just amazing. I was just blown away. It's a big business. It's a big, big, big business. So I share that. So I guess you can get it if you really need it. Go down to that. They were at Atlanta. They got a lot of them there.
Either that or go to that place where TSA takes all the stuff that people leave behind.
I think we've covered the operational update, which is Anthem, Kaiser will be in balance, and we're going to have that kind of in place on or before July 1st. If there are needs for appeals, that's still open to members. So again, we want to make sure if they're eligible, they're getting access to it. So that part's kind of been done, but I think kind of in closure, what a great session. I can't thank you all for kind of joining us and giving us, sharing your insights. I think I will gladly hand the baton because a full day of me is more than enough.
Well, thank you very much. And thank you so much. I know this was quite a schlep to get over here for some of you. So thank you for making the journey. I think everyone here really appreciated what you had to say, and we'll be remembering it all, hopefully. I'm going to turn it over to Salugo for final remarks.
Sure. Do you want to go good to the order first, Chair?
Oh, we can go good to the order. Go ahead, Les. You got to go to the order? Okay. Anybody here? Anybody? Okay, we're good. We've done.
Well, I have.
Go ahead. Go ahead.
Yeah. Hi. We're almost cleared out. Thank you for doing what the offsite heading was, bringing the future of LACERA into focus. I feel like we hit the nail on the head with that one. The retreat brought us focus on AI. Thank you very much. My little passion project, governance, law, disability, pension, pensionability, legal price or legal pension gouging or not legal pension spiking, whatever we want to call it, and healthcare. And you really covered the whole thing. So thank you for that. I want to give kudos to the 3 disability staff that came up and offered and spoke, even though they're very new employees, Maritza, Shea, and David. They did a great job. I have to give a special shout out to the attorneys because they're near and dear to my heart. And I know they're, how hard it is what they do, and they did a great job. We have to give kudos to our steadfast Linda, who is our executive assistant, who has to deal with us, 18 of us every day. Yeah, yay, Linda. Our unfailing AV, Kyle, hi, and Alex, who did a great job. No glitches, amazing. Thank you so much. And then finally, see, I'm going to be the chair one day, and yeah, all right. And finally, I found that the most valuable thing that goes on at this offsite is that we trustees, and I'm sure all of you too, get to meet the people, the staff that we don't otherwise get to meet with. We get to talk to them one-on-one. I got more from Ching after the after the presentation about pensionability. I got so much from chat at dinner last night that my brain is overflowing. But it's that time that we spend together. And what I will say I found from every single person at LACERA that I spoke with is how committed they are to the members and to the mission. So I just wanted to say thank you to everyone.
I was gonna say thank you, Aline, because you said it much better than I could have. But you're absolutely right. This is a really, I think, a very impactful, powerful couple of days. I think you pulled out the stops, good information. Still a lot of things for us to think about. But getting to know the staff, I agree, and each other. I think we came away with the same feeling last night, Mr. Moore and Sean and myself, that, you know, we're at a small table. We don't get this opportunity very often to really sit down and talk with each other. We're always rushing here or there, or there's some other agenda. It's really valuable. And it's this interpersonal relationship. It's this contact with each other that is so important. You know, like thinking about the interaction some of yesterday, even when we disagree with each other, that's good because we don't walk away from here disliking each other, but we think about things maybe in a different light. You know, and sometimes we could say, gosh, maybe I hadn't thought about that before, and I need to think about that. That's so valuable. So I really appreciate, I think having these offsites are very, very valuable. If anybody ever thinks that's just a waste of time, they're crazy. These are not a waste of time at all. I've never heard anybody say that, but if maybe someone on the outside might. The food was good, but the content of the offsite was what really made a difference. So I want to thank everybody on staff, everybody, and particularly those in the back. I know sometimes you're sitting back there wondering, maybe what am I here for? Well, you do play an important role, and we want you to hear what's going on. I know the board takes a lot of time and deliberation in making decisions, and we do it with everybody in mind. The member and the employees of LACERA. So thank you all very, very much for that. And with that, closing comments.
Well said, well stated among the dais. And again, on behalf of the staff, I think it's important that it starts with our trustees in terms of making a deliberate effort to have these engagements and have this offsite outside of our normal cadence of board meetings. As was stated, appreciate all the staff that presented, the staff that were here and learned. And I think to Aline, Trustee Langton's point is the interaction and the informal interaction, you get just as much value in that as well. We have a lot ahead of us organizationally, as was highlighted the last 2 days, but I think the spirit of the team, the organization, the support at all levels is really exciting, and we'll get to work. So with that, thank you everyone, and thank you trustees, and all safe travels back home.